don't have time and next week when you're sick, I'll cover something else,
Yeah.
you know.
Yeah. That's a good point, actually. All right. Vascular path. So I think this is, I'm pretty sure this is one with questions, but we'll see. Okay. So I wanted to first go into the anatomy of like oh my God, the anatomy of an artery. Why does that look weird? Arterial anatomy. And the only reason I mention this is because a lot of the times with like questions or whatever, they'll talk about like intimal scarring or like medial. This is like a medial scarring issue or whatever. And they're literally talking about the layers of the arteries. And it'll help you if you understand like what they're getting at. Like it'll kind of help like, oh, like that makes sense that that's medial because that's like where the smooth muscle is. So that's why that would be increased in size. So the three layers, we have the intima. This is your innermost layer. This is pretty much, I kind of like think of this layer as sitting right on top of like the endothelial cells. The middle layer is your media. This is your smooth muscle. There's some elastic fibers within the media. And then your outermost layer is the adventitia or the connective tissue layer. So it's kind of like the support of it. Um, Sometimes you'll see like externa for this. Adventitia is technically more correct. But if you see externa, they're like, that's the same thing they're talking about. And then don't forget, arteries less compliant than veins, and they're more muscular. And I only mention that because just in case I think on my exam second year, they showed like a picture and was like, is this an artery or a vein? You're like, oh. So we'll go through that a little bit. And then don't forget about vasa vasorum. I specifically am going to talk about vasa vasorum for like some of the pathology states. It's like, oh, the vasa vasorum dies. And you're like, what is the vasa vasorum? And that is specifically the blood supply to the arteries. So I think it's funny. It's the blood supply of the blood supply. But just like the heart needs blood, the arteries need blood. Like they still need blood. So that's kind of brought in with the vasa vasorum. So here's your classic like blood vessel, like artery. This is an artery, not just a blood vessel. This is an artery. So I kind of again think of the intima as being like basically neck and neck with the endothelial lining. So remember whenever I draw like arteries when we're doing stuff, especially with immuno, I always draw like that endothelial lining on both sides just to remind you guys like the endothelial cells line blood vessels. So this would technically be like right below it. Like basically what it's sitting on would be like the intima layer. And again, it's primarily just made up of those endothelial cells, and then it's just like a lining basically. The media, that's your muscle. That's like straight up the muscle. So that would be like right here, like the muscular layer would be right here, and that's gonna have some elastic fibers in there. That's what this blue is. These are like your elastic fibers. But here's your smooth muscle, and then your adventitia, which is the outer. This is really just there for support, just to kind of like group all that together. That's gonna be just really connective tissue. And remember, tunica just means coat. So when you see tunica, you'll see this again when you get back to repro. They talk about like the tunica albuginea. They're just talking about like coats. So like these are like little layers basically. Here's a picture of like a histo version of it. And I like this because you can see the vasa vasorum in this. So again, this is the same thing. Here's the lumen in the middle. So remember when it's the lumens in the middle, that's where the endothelial line sits. So the intima is going to be the one closest to the lumen because that's where the endothelial cells are. You can't see the endothelial cells on here, but it just looks like a thin layer. That's your tunica intima. So that would be this. Whenever you see these squiggly things, that's your media. Those are your elastic fibers. So those are always going to be a part of the media. So your tunica intima in this case is just really tiny, and it really is just kind of like really thin, really tiny. Your media is in the middle, and then the adventitia is like the thickest. That's just your loose connective tissue supplying it, but that's where your vasa vasorum are. So your vasa vasorum, which are the blood vessels supplying this artery, are going to be found on like the outermost area of the artery. Okay, so this is what I was talking about. They can just show you an image and be like, okay, is this an artery or is this a vein? And I put a bunch of pictures like on the next slide too to kind of show you all the different ways you can see it. But just like I had mentioned on the first slide, arteries are super super not compliant. Think about it, they're not supposed to be compliant. We don't want them moving around with our blood flow. We want them being like, no, you need to get to the organ you're trying to get to. So it needs to be nice and thick and muscular. So that's why this is nice and thick and muscular. So you'll always see with arteries this really thick muscular layer. Also with arteries, they will always, always be circular because again, they're not compliant. They're not going to change with just the blood that's there. Versus veins, they're thinner. Like they don't have as much musculature. Because again, veins are supposed to be compliant. That's like the whole point of veins, is to hold as much blood as absolutely possible if they need to. So they're not going to be as muscular, so they're going to have a much thinner media layer. And also, whenever you see a vein, it's always going to be like a really weird shape. And that's just, again, trying to show you like they're very compliant. They can just move around. So even when you're making these slides, they're going to just move around when you're making these slides. So here's some pictures of arteries and veins, just as many as I could find on the internet to kind of help you. This one, I think that this looks a little thick. This vein looks a little thick, but always look at the media layer. So the media layer in this one would be only from like here to here, which is still thinner than from here to here. The rest of this is all connective tissue. I know it's hard to see because it's red on red, but this is all like the connective tissue layer. So the media is like what I'm comparing thickness to. And then here's like more veins. They're all weird shapes. And then here, more veins, weird shapes. And then the arteries are always like circles with like thick media layers where the connective tissue is. Okay, so that makes sense. If you see an image and it's like, which one's the vein, which one's the artery, you can identify it. Perfect. Okay, so then the beginning of chapter 7 goes into vasculitis, and then it goes into, hypertension and all that other stuff. Vasculitis, me personally, and this is crazy that I'm saying this because it's inflammation and immunology, I think vasculitis is like the hardest stuff you're going to get like on boards, on questions. Even the questions I brought in at the end, I just stuck to vasculitis questions because I think that they're very tricky. And this is true when you get to like repro path this year. A lot of the hard repro path is like forms of vasculitis. When they're talking about like, oh, we have intimal hyperplasia with fibrinoid necrosis, you're just like, oh my God. It just seems like a lot of words. So what I tried to do with this was I did do a lot of like because Dr. Sitar does just mention a lot of the stuff you do need to know, but I kind of supplemented with my own stuff that helps me like remember stuff and things that I've pointed out. So a lot of this will go hand in hand with Sitar, but just because like that is what you need to know. But vasculitis in general, itis, inflammation of the vasculature, vasc. But usually with vasculitis, litises, they don't know what causes it, just like most things in immunology. Clinically, I think of this clinically, like you have those inflammatory symptoms, like those very non-specific signs and symptoms of inflammation. So like fever, fatigue, myalgias, those flu-like symptoms. But a lot of the times with vasculitis is what causes like patients to come in or to like seek medical help is because of those symptoms of ischemia. Because a lot of the times with the vasculitis is the inflammation narrows the blood vessel that it's causing the inflammation to, and then you lose oxygen. And that's kind of where you get the pain, the swelling, and then fibrosis will ensue. Because fibrosis is really just the, when you're fixing, like after you lose oxygen to an area, they're trying to like, the macrophages and all those cells are trying to now fix that area. And that's where you get fibrosis. And it's good to kind of start with vasculitis because this is going to come up in every single block. Like you're going to see like various vasculitises and like I said, repro, kidney, like you're going to see like the theme play out over and over again. So a lot of the times with vasculitises, the issue is because of the ischemia. But specifically for chapter 7, you can think of vasculitises as 3 main groups. Your large vessel vasculitis, your medium vessel vasculitis, and your small vessel vasculitis. And this is just what type of vessel is it affecting. If it affects the aorta and like the branches of the aorta, like the carotid artery, the subclavian artery, those types of things, that's your large vessel. Medium is going to be your muscular arteries. Muscular arteries are any artery that leads to an organ. And again, they call them muscular arteries because again, they cannot be compliant. You can't just lose, you can't just like, the blood just can't stop going to an organ. Like organs need blood. So those are your medium vessels. They're super muscular. And just like the aorta is super muscular. I'm not saying the aorta is not super muscular, but like the one, usually when they're talking about medium vessels, they're talking about arteries that lead to organs. And then your small vessels are pretty much like anything else. But a lot of the times that ends up being arterioles, capillaries, anything like that. Here's this image that I don't remember. I think I just found this online. I have actually another one that I put in at the very end when we're done talking about all of these from Amboss, which I really like. But I think this is a really good way to break down the vasculitises because I'm telling you, they're going to give you like question stems and all like 12, however many, all of these are going to be listed as answer choices, and a lot of them overlap. And again, I gave you kind of like my tips and tricks on how to answer the questions, but if you think about it like this, it'll really help. So you have your large vessel, your medium vessel, and then your small vessels, and then you have your ANCA associated ones, so ones associated with like a P ANCA or a C ANCA, and then you have your immune complex vasculitises. So I don't talk about a lot of these. I think, yeah, Dr. Sitar only talked about IgA vasculitis, like in this chapter, because he talks about some of these other ones like in later chapters. So we're not going to do them yet. But this is a really good way to kind of think about these, especially these small vessel ones. A lot of the times, if it's an ANCA associated one, they're going to give you like, oh, there's P ANCA positive or C ANCA positive. So it can help you rule out other ones. But this is what they're referencing. The large vessel, aorta, and like the branches off the aorta. Medium vessels are going to be more of those like big muscular vessels, usually that lead to organs. And then small vessels are going to be everything else, basically, all the way down to the capillaries. Okay, so starting to talk about large vessel vasculitises. So again, your aorta and associated branches. So giant cell arteritis, or GCA. I'll call it like GCA. I underline in every one if they have mentioned if it's granulomatous or if it's like just necrotizing but non-granulomatous. I underline that because a lot of the times they'll tell you like, oh, here's a granuloma, like a granuloma is seen. It can help you rule things out. But I'll try to like make it more intuitive so you're not memorizing like, oh, giant cell arteritis has granulomas. Like I'll kind of help you like with the path to kind of make more sense of it. But anyway, so giant cell arteritis, it is a granulomatous inflammation, so there are going to be granulomas present of the carotid specifically. So the carotid artery is one of those like later branches off of the aorta, but then the carotid keeps splitting. And you'll go into this a little bit more in neuro if you haven't already gone into it in neuro last year. But the carotid continues to branch, basically. So it can branch into the temporal, it can branch into the ophthalmic, and then it can branch into, I'm just going to call them the arteries of the jaw. You don't need to know the names of those, but it keeps branching. And depending on which of these become inflamed, that's going to give you not only the symptoms, but the type of giant cell arteritis it is. The absolute most common is your temporal, like when the temporal branch becomes inflamed. But you can also have ophthalmic branches become inflamed and those jaw branches. Patient population, females over the age of 50. This is almost exclusively going to be females over the age of 50. Like, they're not even going to try and trick you and give you a 25-year-old with giant cell arteritis. This is pretty much going to be female over the... This is kind of like when I was telling you with, like, the lymphoma stuff. You can kind of use age in the lymphomas to help you. You can kind of do that here. I wouldn't be like, oh, a 65-year-old woman, it has to be giant cell arteritis, but I would at least like, okay, this sounds more like it would be affecting a 65-year-old versus like a 25-year-old. So it's just, age is like helpful in that regard. And then, of course, presentation is going to depend on the branch involved. This is another theme that you're going to see with a lot of these vasculitises, that depending on whatever branch is involved is going to tell you what symptoms the patient's going to have. And again, that's kind of what makes these tricky, is because it can kind of vary for us patient to patient. But again, since temporal is like the most classic and probably like likely the one you're going to see, you're going to look for like a female over the age of 50 that presents with a headache. Because that's usually when the temporal branch is like right up here in your head. I actually have a picture of it to show you. So like if that's throbbing, that's inflamed, you're going to have a headache. The ophthalmic branch is going to cause vision symptoms. This is actually like the one that when they say like, oh, giant cell arteritis can present with blindness. That's why if you have involvement of the ophthalmic branch, or if you have involvement with those jaw branches, you can get jaw claudication. And jaw claudication is just like when you start moving your jaw, it's really, really, really painful. And again, it's because of ischemia. A lot of these are all because of like those ischemia. The inflammation is causing ischemia, so it's going to cause pain and like other stuff. So again, kind of instead of just memorizing that there's granulomatous inflammation, think about the pathophysiology behind giant cell arteritis. So there's granulomatous inflammation because this is a cell-mediated immune response. So if you peer back into the depths of immuno, remember cell-mediated response, this is a T cell response. So for whatever reason, and this is actually like a theme that happens especially with females, when they have endothelial damage, the body like overreacts. They think it's like estrogen driven. They don't really know why. You'll see this like with derm, you'll see it with some of the repro pathology states, but especially with females for some reason, when endothelial cells get damaged, it's like the body like just freaks out. It just overreacts and it tries to attack it. So this is one of those instances. So T cells like overreact to like this endothelial damage and you get like this inflammation of these vessels. So there's three things that occur in like a stepwise fashion. So the first thing that happens is inflammation, because again, we have endothelial damage, now we have inflammation. So T cells are going to be involved as a cell-mediated response. Macrophages are going to get involved because again, those are kind of like, they're always around. Those are what's going to turn into giant cells. If you remember with giant cell arteritis, there are giant cells, spoilers. But it's really all the giant cells are the macrophages that are like freaking out. And then certain cytokines get produced. At the end of the day, you're going to get a granuloma from this. Because again, remember, granulomas are basically when T cells kind of wall off what they think is like an infection or something bad. They basically just like make a T cell wall around it. That's kind of what's happening here. Except in this instance, there's really no trigger. It's just kind of like endothelial damage and now the body freaks out. But you do get like this granuloma. Then the macrophages that are there, those giant cells, they produce metalloproteinases. And again, if this is something Sitar doesn't really go into, don't worry about it too much, but it's like just kind of helping you understand what's going on. The macrophages that are in here with the supposed thing that's triggering this, they can produce stuff that can cause further damage to the wall. And then you can also see intimal hyperplasia, because again, now we're like, this is endothelial damage, so we're going to be more like that intimal layer. That's going to be where the intimal layer, those endothelial cells are now just going to like freak out. Now these macrophages are producing growth factors causing hyperplasia of like the endothelial cells. You get hyperplasia. Now we have reduced blood flow and ischemia. Okay, so that's kind of like what's going on with giant cell arteritis. But specifically, that's why we see this granulomatous inflammation. It's because of like these cells that are responding to it are just like stressed and they're just freaking out. Other things, and then this is some stuff that you can look for in prompts. Polymyalgia rheumatica is often present, around 50%. I have seen them try to get people, like I have gotten got by seeing that a patient presents with polymyalgia rheumatica and then automatically like going for GCA, but they don't always line up. So you kind of it's just something to be aware of, but if you see it, it's not like enough to be like, oh, this patient definitely has GCA, because some of the other conditions can also present with polymyalgia rheumatica. And polymyalgia rheumatica, this is something, again, you're going to start seeing in like every single block moving forward. It's basically like when you have proximal muscle pain. So like they'll complain that they have like usually, again, it's usually a woman. They'll complain of having like muscle pain in their shoulders, their hips, their pelvic girdle, stuff like that. It's like very proximal to the trunk of the body. And it's just like a pain. It's like just kind of weird. You can see polymyalgia rheumatica with lupus, with rheumatoid arthritis. Again, this is not specific to GCA. It's more so just something to look out for. Elevated SED rate. This is like one of the only times that SED rate is like clinically important. A lot of the times they use a SED rate, and SED rate is ESR, so your erythrocyte sedimentation rate. A lot of the times they look at that to look for inflammation, but I've noticed in question stems, they'll usually give a SED rate for vasculitises. Biopsy, this is something that's not going to change for GCA. So again, this is kind of what makes these tricky is like the terminology they use. But I'll kind of show you what they're talking about. But what's tricky with biopsies, especially with giant cell arteritis, is not the entire temporal artery is involved if we're talking about the temporal one. So you actually can't use a negative biopsy to exclude GCA because you would need such a big segment of the temporal artery and you can't take that much of it, because a lot of the times with vasculitis it's like you have these areas of the granulomatous inflammation, then it's fine, then you have areas of granulomatous inflammation and it's fine, and this comes up over and over with the vasculitis. So it's kind of like if you have a negative biopsy, you can't rule it out, again, what also makes it tricky. But I'll also show you what it looks like if it is positive. And this is also why if you have a negative biopsy, they still say treat with suspicion. And basically what that means is if you think it could be GCA, even if the labs don't point to that, just give them steroids. because steroids treats it, like cures it basically, and then you don't risk blindness. Like basically they say treat with suspicion because the benefit of treating with corticosteroids is a lot better than the risk of not treating it and then becoming blind.
Wait, Christina, so
Yeah.
I actually saw this procedure. I saw
Oh,
a
like getting a
temporal,
biopsy?
yeah, and couldn't understand why they were doing it. They were like, yeah, she has really bad headaches. And I'm like,
There you
I
go.
kid you not, for years I had no idea why. I was like,
GCA.
what is happening? Why is somebody with like really bad headaches getting their
Getting
forehead cut open into? Like it made zero sense. Now it makes sense.
probably a female over the age of 50.
It was. It really was.
Isn't it cool when you like see things you learn about? You're like, whoa, I learned about that. There you go. Yeah, really bad head. There you go. Exactly what Naomi just said. Really bad headaches and female over the age of 50. Yeah, take a biopsy, sure. Go for it, especially if the ESR is elevated. But if that came back negative, like let's say we didn't see anything in the biopsy, you can still give them corticosteroids. You can just see what happens when you do that. So this is a temporal artery. It is really superficial. So again, like Nay said, you don't want to like be just doing biopsies. You can just treat them if you want. If you suspect it, you don't have to even do a biopsy. Because again, imagine taking out like this entire artery just to like look at it. It's kind of like, eh. So you can do it, but you can also just treat them with steroids. So this is a positive. This would like be what a positive biopsy looks like. Again, negative does not exclude. But what you'd see is a narrowed lumen. This is literally where the lumen is supposed to be. So like the actual lumen of this artery, like a legitimate lumen, it's supposed to be here. You can kind of see the little slit. That's the lumen. So it's very narrow because of all this inflammation that's going on, which is crazy. So you can imagine that's what's causing these headaches. It's like the rest of the like there's no blood flow there basically. Other things you look for, again, this is intimal, right? Because again, they think the cause of this is like endothelial something. The endothelial cells are lining the lumen, basically. So you see like more intimal hyperplasia and stuff. But you have these areas of fibrosis that are occurring as well. So you kind of see like this area here of like inflammation. See how like the little purple cells that we talked about? Those are your T cells. And then we see like an area with not so much T cells and whatnot. This is like just fibrosis. So this is probably like when she had like a previous bout of inflammation, it probably went through it and then it healed with fibrosis. Also in a biopsy, you see giant cells. So giant cells, this is a giant cell. It's basically a large cell that has multiple nuclei. All it is a macrophage that's just massive. It's like an activated macrophage. And then all the way out here, you'll see like you'll just see more inflammation, like more lymphocytes, like things like that. Okay, but again, not seeing this does not exclude GCA. Okay, so that's GCA. When I remember when I was in second year, a kid in my group, his mom had GCA, and he like went into it, and she almost went blind because no one was diagnosing her with this. And then one doctor one day was like, "Let's just start you on steroids." And then they started her on, and I think she got biopsies, and it was always negative. And one doctor was like, "I'm just gonna start you on a steroid." Went away right away, and she literally was like going blind. Crazy. Steroids are your friend here. All right, so then the second large vessel vasculitis, Takayasu. I think that's how you say it. Takayasu, yeah. So again, this is also granulomatous vasculitis. So think, I didn't go through the pathophys again, but, think T cells, think macrophages, that type of stuff. But this Takayasu is going to be at the aortic arch and any of those branch points of the aortic arch. This is also going to be, it's actually more common in females. So a lot of these are going to be more common in females. I actually pointed out the ones that are like you tend to see more in males because those are more rare. A lot of the immune system mediated stuff is more common in females, but this is a 9-to-1 ratio. So it's a lot more common in females than males. And for this, it's going to be young, less than 50 years, Asian females. So again, Takayasu, you can be thinking Asian, but this one's going to be more so young versus GCA. It's over 50. Takayasu, it's going to be young females under the age of 50. They call this pulseless disease because you have, again, think about this. This is right at like the aortic arch branch points. So you're going to basically see weak absent pulses in the upper extremity, as well as having like some visual neuro symptoms. Because again, all those branches of the aortic arch go up. I mean, I know they go down to the legs too, but they go up directly to like the face, the upper extremity, stuff like that. So I know when I was going through this, I remembered I can't take a ya pulse. Take a ya, takayasu. I don't know. It's funny. All right, so just remember, pulseless disease, they will straight up say like weak pulses seen in wrists. Okay. Also an elevated sed rate here, same thing, inflammation, and then you just treat with steroids. This would be like what the granuloma looks like. So this is again Takayasu. I gave you like a little visual because again, these are like is the better you can like learn these instead of just memorizing it. It'll be so much better for questions. But we kind of talked about all of this. But this, I just wanted to show you what like the granuloma looks like in it. It's no different. It's a non-caseating granuloma. It's not TB, so there's not dead cells in the middle of it. But you can see definitely the wall of inflammation, the inflammatory cells, and then like the material in the middle. This is kind of what it would look like. Okay, so those are the two large vessels. Those are a little bit easier. I put with a little asterisk. I feel like they get harder as you go into like the smaller vessels. But so next are going to be the medium vessel vasculitises. So your polyarteritis nodosa, Kawasaki and Berger or Berger. I don't even know. Okay, polyarteritis nodosa, or I call it PAN, and I call it PAN for the mnemonics that I use. Polyarteritis nodosa it's non-granulomatous, and it's a necrotizing vasculitis. So when I just say necrotizing, that just means like there's just inflammation causing, loss of ischemia, and then certain like parts of that will die. That's pretty much what a necrotizing vasculitis means. But a lot of the times too, you can have like a granulomatous and necrotizing. But a lot of the times it's just either a granulomatous vasculitis or a necrotizing vasculitis. This is a necrotizing vasculitis. So there's going to be inflammation to the point where like cells are going to start dying. But what makes polyarteritis nodosa confusing is many organs, like many of the vessels leading to these organs can undergo this inflammation, and then it can lead to ischemia. And as I said before, medium vessels are those that supply organs. So again, you can have a lot of different symptoms. But something to point out with this one is the lungs are always, always, always spared. Always spared. And that's kind of how, and I tried to highlight things that are going to help you like answer it in questions. That's going to 100% help you is knowing that the lungs are spared. Patient population for this are young adults. Males more common than females. Not saying females can't get it, but like this is one of those weird ones where like males actually tend to come up more in the prompts than the females. But your presentation is going to be depending on which arteries are involved. And I tried to highlight the ones that were more important that you would likely be like more likely to see on your vignettes. Renal arteries are typically always involved with polyarteritis. I know it only says 60%, but I always see with the polyarteritis questions, I typically see like hypertension because of like the renal arteries. You can also have like your mesenteric arteries can be involved. So mesenteric arteries are like, your SMA, IMA, those guys. That can cause abdominal pain. It can even cause bleeding into the stool. You can have neuro arteries affected. So this is things like polyneuropathy. So like you can have like tingling, you can get strokes from it. And usually the skin is involved, which is just kind of like a weird thing because like the skin doesn't have like an artery that supplies the skin. Like there's not like a, like a muscular artery that supplies the skin. But just know, like in like a lot of the times in the vignettes too, there's going to be rash, ulcer, like there's just going to be something with the skin as well with this polyarteritis nodosa. This is also associated with hepatitis B. So they tend to find if there's someone with polyarteritis nodosa, they have a positive surface antigen for hep B. So a lot of the times it's either like, and having positive surface antigen usually means you have hep B infection because this is an antigen. So when you do, and I don't know if you guys have done hepatitis, like those marker testing, or if you haven't done them since like GI last block, you'll definitely do them this GI block. Like you'll learn them really, really intensely. If you have positive surface antigen present, that means you pretty much have hepatitis B present. Because again, it's not an antibody, it's the antigen of the virus. So this is why I kind of call it PAN for my mnemonics down here. But typically it's like, okay, well, how do you diagnose PAN? Like it seems like any organ can be involved. It's just like anything with hepatitis B. So usually what they say is a young adult presenting with a stroke or an MI. Because that's weird, especially when you're taking boards, like you're thinking like stroke, an 85-year-old, like that's kind of weird if a 30-year-old comes in with like a heart attack. You're like, that's really strange. So that you can consider it that, but not obviously if someone comes in with hypertension, you can also think about it. So with PAN, pulmonary artery is not involved, PAN. It's transmural, but panmural inflammation of the arterial wall. And then it's often associated with hepatitis B. I know it's really grasping at loose straws here, but hopefully that helps you. Just remember, pulmonary artery not involved, hepatitis B. Those are going to be like the two really main ways to differentiate between that one and another one. They can also show you biopsy. So like I said, remember, this is not granulomatous. This is going to be more of like a necrotizing biopsy. But with a lot of the vasculitis, this is something we talked about with GCA. If you take biopsies of the lesion, you might catch a new lesion, you might catch an old lesion, because a lot of the times there's inflammation, then it goes away and it gets fixed. That's your fibrosis. Then you get a new lesion, it goes away and it gets fibrosis. So it's going to like depend, like your biopsy also is going to change, like with most of these when you see them. So this is an example of like an early lesion. So here's your transmural inflammation. I know you can't really see. I don't even know where the lumen is in this one, honestly. But clearly all of the walls, the intima, the media, the adventitia, they all look like there's, these purple cells present. So I would say, yeah, that looks like transmural inflammation. And then there's fibrinoid necrosis. So hopefully you guys watch, Golian's chapter 1 or whenever he goes into the types of necrosis. That'll come up again every single block. But there is going to be like this pink stuff present. That's like going to be like your fibrinoid necrosis that's occurring. And eventually this nodule will heal and you'll get fibrosis. That's actually where like the nodosa in polyarteritis nodosa, those nodosa is referring to the nodules that get like the nodules of basically fibrosis when it heals. So that's going to look like this. And I put this here because there is like another one that kind of looks like a string of pearls appearance. A lot of these overlap, unfortunately. But this, I would actually say that this is like the splenic artery. This kind of looks like the spleen here. So again, a lot of the arteries can undergo this, but when they're talking about like these nodules occurring, it's literally like the nodules of like healing that it just think about like Crohn's disease. Like if there's transmural inflammation of the bowel, it just gets like, that's why you see cobblestoning. You can kind of think of it like this, like you have these nodules here because of like all that inflammation that's occurring. So they say that this is like a string of pearls look on x-ray. There's another one we're going to talk about later, which is a string of beads. It's all the same. It's just, it doesn't really help you diagnose it. It's just, I kind of wanted you to just kind of see like, this is like another theme that you would see with like these transmural inflammations. Okay. More on this, you treat with steroids and cyclophosphamide. I highlighted cyclophosphamide because like that's a freaking chemo drug and you're giving it for a vasculitis, but they can actually be fatal if you don't treat it, especially because it just stops blood flow to like a lot of your major organs, like your heart, your kidneys, your GI tract. So that's why you can give you can also give steroids. I tend to notice like cyclophosphamide a lot more. But again, if they have positive surface antigen for Hep B, you need to treat the Hep B. So just keep that in mind as well. All right, Kawasaki. So Kawasaki, this is also going to be a necrotizing vasculitis of unknown etiology. They don't know what causes it. They think it's something viral, but they have no idea. No granulomas. So again, this is going to be a true necrotizing vasculitis. So you're just going to see dead cells, probably due to like blocking off blood flow. You'll see nonspecific signs and symptoms of inflammation, but specifically for Kawasaki, you'll see fever, conjunctivitis, mucositis, so you'll see strawberry tongue. You'll see like a desquamating rash on the palms and the soles of, like on the palms of hands, soles of feet. It's like where like literally like the skin flakes off. And then cervical lymphadenopathy. This is like, it's not a triad. What is this? A quartad? I don't know. But you need, when you see this in like a young Asian child, Kawasaki. And and that's why I highlight so much on this slide, because this is something that they can die if you don't treat them properly. Patient population, Asian children, usually they say less than 4. If you have a 6-year-old and it sounds like Kawasaki, like just treat it like Kawasaki, but that's usually you're going to see like a younger Asian child. Again, with the name, to help you with the like what country they're from. And usually the coronary artery is involved. So it can be involved in terms of like you can get a thrombosis and then that causes an MI, or the coronary artery can like undergo an aneurysm and then it can rupture. So a lot of the times though, when you're doing prompts with Kawasaki, they'll talk about like a 4-year-old that had a heart attack and you're like, what? But a lot of the time, that's if you let it go. You don't treat it properly. You see these signs and symptoms and you let it go. And the reason why it's really important to recognize that this could potentially be Kawasaki is because you treat with aspirin. And again, you never ever, and I put this here, you literally, like, this is like mom 101. Like, you're never supposed to give like your child aspirin, which I don't even know if you guys have done the aspirin video yet for Sketchy. But if you give aspirin to a kid, you can cause Ray's syndrome, which is literally like their liver dies. So that's why a lot of the times, like, you are never supposed to give aspirin to a kid. And here it is being like the life-saving treatment for a disease in children. So that's why it's really important to recognize Kawasaki like as soon as possible, because the treatment is really weird for it. You can also give you can also give IVIG. Oh, it's also in the orthomyxo video? Cool. Orthomyxovirus. What is that, the flu? Probably. Honestly, you know why? Because to not give aspirin to a kid. Yeah, it's just because it's really important. Like, you're really not ever supposed to give aspirin to a kid. But that's, again, if I were to guess what questions you would get, it would be something about this, because it's just like such a weird thing, but they can die if you don't give them aspirin. So it's like you're sitting there, you're like, well, you just said I could die if I give them aspirin. So that's why it's like it's really important to be able to recognize these symptoms. And I even put like a screenshot from the Sketchy video. I honestly just found this online. I don't know whose highlighting this is, but even this is in the aspirin video. Here's like when they talk about Kawasaki, you need to give aspirin. And they even said in the Sketchy video, which is interesting, it's the most common vasculitis in children. Sure. But you can think about this like Kawasaki, like whatever this is, ATV. You give aspirin for it. Here's just more kind of pictures of it to kind of visualize it. But remember, you're looking for like the conjunctivitis of the eyes, mucositis, the strawberry tongue, the soles of the feet and the palms of the hands, and then this desquamating rash everywhere. Cervical lymphadenopathy, and then a fever. This is like your classic Kawasaki, again, in like a small Asian child. Give them aspirin, because again, if you don't, they can undergo like heart attacks, they can undergo coronary artery aneurysms, things like that. And then also, and this is kind of like, again, because it's so important to kind of recognize, anytime you see a small child with a rash, high fever, unresponsive to antibiotics, you can consider Kawasaki. Again, because it is so important to identify, like, the risk and the reward it's not an even ratio. So small child, rash, high fever, doesn't react to antibiotics. That's like it's not responding to antibiotics. This is an inflammation thing. This might be Kawasaki. Okay. And then the mnemonic for this one, it got messed up. Crash and burn. So crash tells you the symptoms. So conjunctivitis, rash, adenopathy, strawberry tongue, hands and feet, rash on hands and feet. And then burn is that fever. This usually will always have a fever for at least 5 days. I even think so it even said it on here. For at least 5 days, that's going to be more of like your telltale sign. And then I put like a little fire over the ATV quad from the Sketchy video for visuals. All right, and then Buerger disease. When I was in a cardiorenal block second year, I had Dr. Papa as my facilitator, and he said he told someone that this disease doesn't actually exist. So, but we're still going to learn about it. But he said he's never seen it clinically. He's never heard of anyone seeing it clinically, but whatever. You might still see it on questions, so we're going to talk about it anyway. But just know that Dr. Papa doesn't think that exists. So if he's writing the exam, just saying. But this is
now.
What?
We have him now, and he didn't interrupt somebody when they're talking about it, so maybe he saw it.
Maybe he learned his lesson.
Right.
His lesson, maybe. You're so lucky you have him. I love him. Okay. So this is a necrotizing vasculitis, fingers and toes. Again, you're going to see death. You're not really going to see granulomas. I only have like one slide on this because it's literally going to be in like a smoker. That's pretty much it. It's going to be in a smoker that has like basically losing their fingertips and their toes. So you're going to see gangrene, ulcers, auto amputation of fingers and toes. You might see Raynaud's phenomenon like before that. But it's literally going to be, it's all about smoking. And the idea behind this, because I don't know if it actually exists, the idea behind this is that smoking is going to damage like the vessels furthest away from the heart, which would be like the ones of like the digits. And then eventually those are going to die off, and then the areas furthest away from the heart are going to die off because those vessels are dying off. That's the idea behind it. You can't revert if you have like necrosis, you can't reverse that. But you can stop further digits from dying. So they say treatment is smoking cessation, but it's not for the ones that have already like died. That's pretty much it. It's again, I've actually gotten questions on Berger's disease, like just doing questions, like back in the day, and it's very obvious that this is what they're talking about. Okay, the trickiest. So this is what I want to spend, a very high portion of the rest of the, not the rest of the time, but like I want to spend a lot of time on this because this is where they will get you. This is the one. So I tried to put in every single way to help you guys remember these as possible. These are all so similar. It's going to be like one word that's going to differentiate between one or the other. So, and especially like at the end, I put in a ton of questions at the end. There's no way we're going to get to all of them. I put in every question I could find about the vasculitises, but especially about these guys, just because I really want you to start seeing patterns of how they're asked, because it's going to be kind of like when we were talking about coagulation and like, primary, secondary coagulation systems. Yes, some of the things overlap for others, but what does it sound more like? And that's kind of like, and the only way to get good at that is by seeing questions over and over and over again, in my opinion. So just know there's a bunch of questions at the end, even if we don't get to like any of them. Well, we'll get to some, but if we don't get to all of them, they're all there. Do them as much as, just kind of start picking up on those patterns, okay? Because these are going to be the tricky ones. All right, your first one is Wegener's. A lot of this, again, Sitar says, but I added my own notes just from doing questions and like learning about these in other, instances. So this is Wegener's granulomatosis. I don't think it's called Wegener's anymore. In my pathoma book, he still calls it Wegener's, but it's also from like 3 years ago. So I don't know if he's updated it, but I don't believe it's actually called Wegener's anymore. So when you're doing questions, they're going to call it granulomatosis with polyangiitis. Okay? So they're the same thing. I still reference it as Wegener's because I remember it as the C disease, and I think of it as Wegener's with a C, which kind of helps me. But just know that they're the same thing. Wegener's and granulomatosis with polyangiitis. It's in the name. I also like remembering that it's, granulomatosis because there are granulomas, which is good. It is also necrotizing. That doesn't mean much to me. It's more so like, is there a granuloma or not? Because that's going to help you rule some things out. This one has granulomas. I don't know if I might have put on another slide, but you can think of it as like non-caseating granulomas, non-caseating, another C. So to help you remember, there's granulomas in this one. Okay. So this one is the C disease because and this is just straight from Dr. Sitar, if you draw a little person and then you draw a C, the C is going to touch all the areas that are affected by this disease. So the nasopharynx gets affected, the lungs get affected, and then the kidneys get affected. And so that's what he means by it's the C disease. It hits the nasopharynx, lungs, kidneys. This is going to be middle-aged males. I also highlighted males because super weird, it's males. But doesn't mean you can exclude females. But presentation for this is going to be chronic sinusitis. So just someone that just seems like they have, inflammation of their sinuses, nasopharyngeal ulcerations, so stuff with the nasopharynx, like maybe they have sore throat all the time. So that's like the nasopharynx part. Hemoptysis and bilateral lung infiltrates. This is just, again, this is a vasculitis of these different organs. So you can imagine how it's going to present. If I have inflammation of the sinuses and the nasopharynx, that's how it's going to present. If I have inflammation of the vessels in the lungs, I might be coughing up some blood. And then same thing, if I have inflammation of the vessels in the kidneys, I might have hematuria. But again, with these vasculitises, they go through so many organ systems that's why these are not going to go away. These are actually what's going to make future block pathology really difficult when they throw these in there. Because you're like, oh, hematuria, like, oh, maybe this is a nephritic disease. And you're just like, oh, God. So it's just, if you learn these really well now, I promise it'll help so much when you get to future blocks, especially for boards. But with this, continuing with the C disease, You have a positive for C-ANCA, which is, again, just a lab test. There's C-ANCA and P-ANCA. This is positive C-ANCA. And you also treat with cyclophosphamide. You also can treat with steroids, but this is another one where you treat with cyclophosphamide. So here's kind of like the granuloma in this granulomatous disease, polyangiitis. Here's your granuloma right here. So this is it. You have like your inflammation, you have like your walled off fibrosis. You can imagine like your T cells, your macrophages, your giant cells, whatever. And then just tons of inflammation elsewhere. Like this is a full vessel. Like just keep that in mind. This is like a vessel wall. There is tons of inflammation here. There's a granuloma, there's necrosis, there's like areas of like pink dead cells here, there's fibrosis, there's giant cells, that's what's causing the fibrosis. There's just all sorts, oh no, that's not a giant cell, these are giant cells, these are all your giant cells, just causing more and more fibrosis occurring. Again, those are just macrophages. But again, this is just to kind of help you visualize it. They'll never just show you a slide and be like, what is this? But just to kind of like see it, you're like, okay. What I have learned from doing questions for granulomatosis with polyangiitis, these are the three things that are usually going to come up, what I've at least seen. There's going to be a vasculitis, which is going to present as a palpable purpura. And we'll talk about purpura when we talk about like the IgA nephropathy thing. Well, not the nephropathy, but the IgA one in a little bit. But there is a palpable purpura for this one, again, because we get this necrotizing vasculitis everywhere. You have upper lower respiratory tract infections. Again, this is because we have chronic sinusitis, nasopharyngeal ulcers, hemoptysis, that type of stuff. So upper respiratory tract, that's more of your nasopharynx. Lower respiratory tract, that's going to be more of like your lungs, which we've talked about. And again, you can see those infiltrates. They can be like cavities in the lungs. They can just things to look for. And then glomerulonephritis and nephritic syndrome. Again, we're inflaming the vessels of the kidneys. You can bleed into the urine. That's going to present with like kidney failure almost. So like elevated serum creatinine, proteinuria, hematuria, red blood cell casts. Okay. So I guess it's not that helpful because it's everything we talked about in our C disease, but at least when you're doing questions, this is going to be present in every single vignette about this disease will have these three things in it. Whereas some of the other ones is like, oh yeah, sometimes this is here, sometimes this is not. It depends on the organ that's involved. These are always going to be here. All right. The next one is microscopic polyangiitis. But I usually call this one necrotizing polyangiitis because, again, with this other name, granulomatosis with polyangiitis, that's my granuloma one with polyangiitis. This is going to be my necrotizing polyangiitis. And yes, I know necrotizing, technically it's necrotizing in the granulomatous one, but that's what I said. I don't really care. Is there a granuloma? Is there not a granuloma? This one, no granuloma, just necrotizing, because technically they're all necrotizing. They all cause like death because of this inflammation leading to ischemia. But this is my necrotizing polyangiitis, but on vignettes and stuff and question stems, like when they have answer choices, they're going to talk about it as microscopic, which is just silly. But this is going to be the one that also involves many organs. But specifically with this one, the lungs and the kidneys are going to be involved. So you're like, wow, that sounds exactly like Wegener's. You're like, nice. But this is only the lungs and the kidneys. We don't have chronic sinusitis. We don't have like the nasopharyngeal ulcerations. It's really just the lungs and the kidneys. So that's one thing that differs from Wegener's. The second thing is that's why I call it necrotizing polyangiitis, because there's no granulomas. Wegener's has your granulomas. That's your granulomatous polyangiitis. Okay, so that's my second one. And then my third one is in Wegener's, since it's your C disease, that's a C-ANCA. This is a P-ANCA. So positive P-ANCA. And then for this one, you can treat with cyclophosphamide, which is annoying because it's a C, but you can also treat it with steroids. So for this one, really the big thing is just keeping this one. So it actually is also very similar to the next one we're going to talk about, which is great. But just keep in mind, like, that's how you differentiate this one with Wegener's. And then we're going to use this one also to differentiate with the next one we're going to cover. But before I go into that, I wanted to briefly talk about a C-ANCA versus a P-ANCA, because it's like, what does that mean? And basically these vasculitises are your body's making autoantibodies against your white blood cells. So when it's kind of like when you guys, I don't know if you guys learned that much depth about lupus, but you can have different types of autoantibodies in lupus. You can have anti-Smith, you can have anti-double-stranded DNA, you can have anti-nuclear. That's kind of like what, like for lupus, those are the just different types of the same thing. This is kind of the same thing. It's like these are different types of the autoantibodies you can have for like these vasculitises, these small vessel vasculitises. So when you make an autoantibody against the cytoplasmic part of the white blood cell, so like the cytoplasm, that's a C ANCA. I'm making an I think it's like anti-neutrophilic something, I forget. But you're making an antibody against the cytoplasm, that's your C ANCA, versus if I'm making autoantibodies against the perinuclear area of the white blood cell, so the part around the nucleus, that's my P ANCA. I would have loved this to be an N ANCA because that's nuclear and then cytoplasmic, but whatever. But P ANCA is fine because it's going to help you because you remember this now with necrotizing polyangiitis is a P ANCA. Necrotizing poly, yeah. Okay. All right, Churg-Strauss. This is the one. So again, now, before I go into Churg-Strauss, this one is very similar to this one. This one is very similar to Churg-Strauss. Okay. So again, that's why I'm really emphasizing, like, learn these differences. I tried to help as much as possible. But the other name for Churg-Strauss, and this is what they're going to call it on your exam, is, well, on boards and questions, eosinophilic granulomatosis with polyangiitis. Okay? Because we love that. But at least that tells you that there's eosinophils in it, and that's like your main difference between this one and your microscopic polyangiitis. Okay? But this has granulomas. Great, it's in the name. So there are granulomas. So it sounds a little like Wegener's, right? Wegener's. So we have granulomatous inflammation. Churg-Strauss, though, has eosinophils. Tons of eosinophils. They think that this is actually triggered, this disease, this vasculitis is actually triggered by eosinophils. So when you think eosinophils, maybe you're thinking like allergies. You should be thinking like maybe like asthma, maybe. So lungs are involved. So again, that's going to be another similarity to Wegener's. And then your heart also gets involved with this one. So heart and lungs, eosinophilia, heart and lungs, granulomatous inflammation. Almost always, and that's why I highlighted this, the patient in the prompt is going to present with eosinophilic asthma, meaning they're going to come in with like an asthma. That's what's going to bring them in is because of their asthma. They're going to be like, my asthma is really bad, or maybe they don't know they have asthma. It's like they feel like they can't breathe. They have these symptoms of asthma. And then they test them and they have elevated IgE. So they can kind of identify like, oh, this patient has like an eosinophilic asthma. Like the eosinophils producing this IgE is what's causing this asthma. And you'll actually go into this when you get to Pulm. Some of the asthma drugs nowadays are monoclonal antibodies against IgE. Like one of them, I think it's called omeprazole. No, that's a GI one. Something with an M. I don't remember. But when you get to it, you'll be like, oh, that's the one Christina was talking about. So it's a subtype of asthma that's caused by IgE, and you can block it with a particular drug. Those are the types of patients that get Churg-Strauss. Okay, so those patients with eosinophilic asthma are going to be brought in because of their asthma, and then they're going to realize that there's like this granulomatous inflammation causing like death of the cells. Other things you can see, and this is again just from doing questions and seeing these things pop up: skin nodules and purpura, sinusitis, which again, great because it sounds like Wegener's, allergic rhinitis, polyneuropathy. Polyneuropathy, they're not going to say patient has polyneuropathy. They're going to say like patient has like a unilateral foot drop or something like that. Okay. This one has a serum P ANCA. So again, here's another way to kind of differentiate it between Wegener's and of course the elevated IgE, because again, that's always going to be a feature of this one. So be able to compare and contrast this with necrotizing polyangiitis, the microscopic, the one we just talked about it before. So I gave some ways to kind of differentiate it. So in necrotizing polyangiitis, there's no vessels affected in the upper respiratory tract. So you don't have sinusitis, you don't have rhinitis. It doesn't have granulomas, and then it's associated with oh, did I do this backwards? And it's associated with, oh no, that's the same thing. Okay. A P ANCA, not a C ANCA. Sorry. So that's a similarity, is also the P ANCA. And then this is kind of what a granulomatous biopsy looks like. It has a bunch of, see, notice all these pink cells? These are all eosinophils. So if you zoom in on these cells, they're like bright pink. That's your eosinophils. Here's your big ass granuloma. So big granuloma, and then all the cells in the like the surrounding area are pink. So that's your kind of like your eosinophil. Okay. So those three especially are really, really big to differentiate. Eosinophilic granulomatosis polyangiitis, microscopic polyangiitis, and then Wegener's granulomatosis with polyangiitis. Okay. And again, like I said, I gave you guys so many questions on those at the end to kind of just sift through and figure out how to, like, the typical presentations. Okay, HSP, Henoch-Schönlein purpura. That's not how you say it. HSP. This is basically an IgA immune complex deposition, which is super weird because remember, immune complexes is going to be antigen antibody complexes. IgA typically doesn't do that. IgA typically is just found as a dimer, so it dimerizes with itself usually, and then it just circulates. It's found in mucous membranes and stuff. But in this instance, this is like one of those rare ones. It forms immune complexes, and then those immune complexes can deposit places. This is the most common vasculitis in children, although Sketchy said Kawasaki was, so now I don't know what to believe. But Dr. Zatara says that this is the most common vasculitis, so I'm going to go with this one. The presentation for this one is palpable purpura, but again, a lot of the times, a lot of these have palpable purpura, so you can't always use that to diagnose. But if it's a child with palpable purpura on the butt and legs, that's usually going to be like let me think of HSP for this one. It's palpable, meaning like you can literally touch it and it's not flat. It like feels like there's a nodule. Those are those immune complexes. And then also think about like when we talked about like lupus nephritis, when like those like type 3 hypersensitivities, when they deposit places, typically they deposit in the kidney. Same thing happens here. We see immune complex deposition in the kidney. You can get hematuria from this. They can also deposit in vessels in the GI tract, so you can get GI pain. There's a whole bunch of different symptoms you can get from this one. But usually, and again, this is another way to kind of help you differentiate between this one and other ones, it's following an upper respiratory tract infection. Hopefully that makes sense, because upper respiratory, you would make a lot of IgA because it's something in like the mucous membranes, the upper respiratory tract that's like up here in like the sinuses and nasopharynx. It's self-limiting, meaning like it will go away, but those symptoms are going to be caused when you have these IgA immune complexes. If the kid is really in pain, you can treat with steroids, but it eventually will go away. And then here's just kind of like a little picture showing it. Usually they're going to be on the legs and the butt, but you can get some elsewhere. And of course, joint pain. Again, just think about type 3 hypersensitivity. This is kind of like going to be like a type 3 hypersensitivity, where it's like you have like, usually with all the type 3s, you get deposition in like the joints, the kidney, things like that. Here's like another picture. I put a picture here of like another example of purpura. I think this one's fine, but this looks like little bruises. This looks a lot more palpable. Like if I touch that looks like it's gonna feel like a nodule. And then like the last thing we're gonna talk about is like, you know, hemangiomas and like those things. An important way to differentiate between like a hemangioma and like something like purpura is like, does it blanch or not? Purpura does not blanch. I know that's not a child. It's okay. I didn't look it up in HSP. I just looked up purpura. Thank you. Maybe he is a child. He's just very mature. He's a very mature child. Maybe. I just wanted to show you guys purpura, because this is like not a great. This just looks like bruises. This is like what purpura looks like. It like looks really intense, and like if you touched it, it would like be raised. But if I were to try and touch it, it won't blanch, meaning it won't get white. Like if you have like a mosquito bite or something and you touch it, it'll like, if you press on it, it'll get white. It's not a good example because that's not bleeding, but you get what I'm saying. If you were to touch this would not like push on it. It would not turn white. So that's not blanchable. And I liked this picture because it shows like this is where the bleeding is occurring. It's in the skin. So if you push on it, it's not going to go anywhere. It's already in the skin. Versus like something like a hemangioma, which is a blood vessel that becomes like that starts bleeding. If you press on that, it can escape. So blanching versus non-blanching are very big features of like identifying what type of lesion there is. So I just wanted to give you the example of like these are not blanchable because they bleed directly into the skin. And then in vignettes, they might not say purpura because it'll give it away, especially with HSP has purpura in its name. So they might not say purpura. What they'll say is there's raised, palpable, violaceous like lesions. Violaceous just means purple. Okay, but a good way to kind of think about like it's an IgA vasculitis. Literally, IgA makes these immune complexes and then it deposits just randomly throughout the body. Okay, and then this was a picture I was talking about when we were done talking about the vasculitises. This is from Amboss. I really like this one. It's the same as the first one we talked about, but it has all those updated names. So like granulomatosis with polyangiitis, this is Wagner's. Eosinophilic granulomatosis with polyangiitis, this is Church-Strauss. And then microscopic, this is the one that I call necrotizing. Okay, we didn't talk, then we talked about, IgA vasculitis, this is HSP. So they kind of got away from using the names, which I think is good because it helps you kind of think about it more. Like, oh, is there granulomas? Are there not granulomas? We didn't talk about cryoglobulonemic vasculitis. This is from like hepatitis C. When you cover hepatitis C, probably in the GI block, they'll talk about cryoglobulonemic vasculitis, and then we can talk about it then. But it's basically like your body makes IgM to hepatitis C, and then it just deposits places. And it's kind of similar to the IgA vasculitis, but now it's with IgM. And it's usually in patients that have hep C. But I don't think that wasn't in Pathoma. It's probably not going to be on. I didn't even touch on it. Okay. Okay, do you guys have questions about any of those guys? Like I said, all the questions at the end are going to be about the ones we just covered. All those vasculitises. Okay, yeah, I didn't really put any questions. We can do these later, but you're going to see, like, these are the hypertension, like, aortic aneurysms, dissection. These are so common. You're going to see these a lot, like, moving forward. But I think the vasculitises really need time and, like, effort to, like, get those down. Okay. All right, hypertension. So hypertension is, I know you guys all know what this is, but it's really important to understand these various definitions of hypertension, especially for, like, pharm, which I kind of put in here a little bit, but like when you guys are doing like learning like the antihypertensive medications, and it's like, oh, you give this for hypertensive urgency versus hypertensive emergency, give this for primary hypertension versus secondary. It's just important to know what they're talking about. And I do know like these things change so frequently. This is what was in my Pathoma book, but again, that's from 3 years ago. It already could have changed. So go off of whatever is the most updated version. Okay. It changes all the time. And with, again, hypertension, increased blood pressure, it can be due to like a pulmonic cause. Like you can have like a, pulmonary hypertension or a systemic cause. So like one of those, the normal hypertension that we all think about. Back in 2019, it was considered anything greater than or equal to 140/90. Primary is most common. When it says primary hypertension, and we kind of talked about this briefly, but like primary, like hypertension is the cause, but they don't know why. Like they have absolutely no idea what's causing these patients to have hypertension. It's not like a virus or anything. Like there's no like true cause. This is what's most common. This is like what most people have is like hypertension. Risk factors are age. So if you know like older people, they tend to have higher blood pressure. Race, there's an increased risk in African Americans and a decreased risk in Asians. Obesity, stress, all these ones that you've heard about. Lack of physical activity, high salt diet. That one actually makes sense, right? So if we have high salt, you're going to reabsorb more water. You're going to increase your blood volume, which is going to increase resistance, total peripheral resistance. Secondary hypertension, this is not like the, primary, what is it? Oh my God. What's like an endo thing? Thyroid. Primary hyperthyroidism. That is when like the thyroid is making tons and tons of thyroid hormone. Secondary is when the level above it, and then tertiary 2 above it. That's not the case with primary and secondary hypertension. It's like the cause. So primary, they don't know what causes it. Secondary, they do know what causes it. It's secondary to renal artery stenosis. And a lot of the times what causes renal artery stenosis is going to be atherosclerosis in like elderly males and fibromuscular dysplasia in young females. And we'll talk about fibromuscular dysplasia. That's another one that's going to come up so frequently, just like polymyalgia rheumatica just is going to come up like all the time now. Fibromuscular dysplasia is going to come up like all the time now. Like you'll just start seeing it more and more. But we'll talk about it. So renal artery stenosis, this is a really great opportunity to tie in pathophys, like physiology, and whenever a pathology state can tie in path, they love it. A pathology state can tie in phys, they absolutely love it. So thinking like, how does a unilateral renal artery stenosis cause hypertension? So on this is like the right kidney, and then this is the left kidney. The right kidney in this instance has decreased renal perfusion because less blood is able to get to it all the way over here because of this like atherosclerosis. So this might be like an elderly man. Over here, since this one is not getting as much blood, this is actually going to get more blood than it's used to. So this kidney is going to have increased renal perfusion. So on the one with the stenosis, since it thinks it's getting less blood, now it's like the body thinks that, you know, now it thinks like the body's losing blood. So it kind of kicks in that center to be like, oh, we need to reabsorb a lot of blood right now because like maybe the kidneys think the patient's bleeding out basically. And this is kind of the same idea as like with heart failure. It's kind of the exact same pathophys as with heart failure. The decreased blood volume kind of triggers the kidneys to undergo the renin-angiotensin-aldosterone system. So decreased renal perfusion, RAS is going to turn on basically. So renin is going to increase the amount of angiotensin 2, which is going to increase aldosterone. So we're going to get angiotensin 2 dependent hypertension. This side, since it's getting more blood volume, it's like, oh, we don't need renin, aldosterone, angiotensin. We don't need that system. So it's actually going to decrease that system, and it's going to increase sodium excretion. This is known as pressure natriuresis. And this is actually why for a really long time, you might not even know that you have renal artery stenosis because the other kidney kind of compensates for it, which is really interesting. So here's your pathophys. So we have decreased renal blood flow, and this is going to be sensed by your JGA cells. So those cells of the juxtaglomerular apparatus. And then those JGA cells are going to respond by producing renin. So again, we're going kind of tying in cardio and renal really nicely here. So those JGA cells, again, they're going to sense the decreased blood flow, produce renin. So now we have elevated renin. Renin is going to convert angiotensin 1 to angiotensin 2 via angiotensin converting enzyme, or ACE. Now we have elevated angiotensin 2. Angiotensin 2, the two main things that it does is it's going to promote the adrenal gland to release aldosterone, and it's going to trigger the sympathetic nervous system. From here, aldosterone is going to cause sodium and water basically to be retained. So remember, aldosterone acts on the nephron to reabsorb sodium and water. And then on this side, the sympathetic nervous system is going to cause vasoconstriction. Because again, this is kind of where it gets tricky with like, if you think you have decreased blood volume, you're actually going to vasoconstrict, increase that total peripheral resistance. This is why. The elevated angiotensin 2, remember it acts on alpha-1 receptors, it causes vasoconstriction. You get contraction of arterial or smooth muscle, increases total peripheral resistance, increase in blood pressure. And then your sodium and water retention, if the patient already has heart failure, they're gonna decompensate. And this is when they go into like, oh, decompensated heart failure plus or minus preserved ejection fraction. So I know this is like not heart failure, but it's kind of the same path. But heart failure, they're saying that there's a preserved ejection fraction because the heart's fine it's fine. What's causing that decompensation is now this increase in aldosterone and angiotensin 2. And then finally, the last thing that happens is this sodium and water retention, as well as this sympathetic nervous system activation, basically causes now uncontrolled hypertension, because especially with the sodium and the water retention, it's happening in the distal convoluted tubule. So if we're retaining water in the DCT, we're going to expand plasma volume. This just keeps going over and over and over again. And that's what's causing that uncontrolled hypertension. Nice little fizz review. So how do I test for this? So you can test for this. Sorry, my dog is, do you guys hear my dog? He's like yelling at me. No? I'm gonna let him just out my door. Oh, just kidding. Okay, no, I'm not. All right. I think he just wanted attention. Hi. Okay, he'll go to sleep. Okay, so how do you kind of diagnose hypertension? So we have the diagnostic. We know it's greater than or equal to 140/90. You're also going to get that elevated plasma renin. So again, that's kind of like, that would be like your secondary hypertension with that the renal artery stenosis. So elevated plasma renin. And then you're also going to get unilateral atrophy of the kidney. So remember, the kidney literally can become smaller if it's losing blood flow. And again, you might not even know this is happening because the other kidney kind of makes up for it. So, oh, I thought I put a picture. I guess I didn't put a picture. So literally the kidney would shrink. And that could be like an indication that the patient has like unilateral renal artery stenosis, elevated plasma renin, and then very high blood pressure. Okay, fibromuscular dysplasia. So again, like I said, this is just something that's just going to keep coming up in like blocks. This is not an inflammation. So I do want to point that out. This looks very similar, if not exactly like polyarteritis nodosa. Remember that one with the splenic artery, and then it got really inflamed. So I kind of talked about it as like cobblestoning. It's kind of like the inflammation is causing like these areas of fibrosis that look like pearls. This also looks like a string of beads or a string of pearls, but this is nothing to do with inflammation. This is a defect of the blood vessel wall itself. So basically what happens is these large and medium-sized vessels actually thicken, but it's not because of inflammation. It's because of the wall itself. It's like literally hyperplasia is occurring, but not due to inflammation. A lot of the times with fibromuscular dysplasia, it's of the renal artery. It's like, 85% of cases actually have renal artery involvement with fibromuscular dysplasia. Are you done whining? Do you guys hear him? Oh my God. But anyway, so this is a picture just straight from Amboss where I'm just gonna give him one pet. Just one pet. Just so he stops. Okay. Okay. It's okay. Okay. All right. He hurt himself. I had to put the little thing on his neck. I think he gets in fights with chipmunks. I really do. I see him like getting in fights with chipmunks, and then he comes back with all these scratches on his tail and he bites at it. Okay. Anyway. Okay. So anyway, so this also has a string of beads. Oh my God, he's sorry. I'm gonna let him out. Sorry. All right. Go. Sorry, he kept whining. Okay. All right. So fibromuscular dysplasia also has that string of pearls, string of beads appearance at the renal artery. Remember with polyarteritis nodosa, it can be like any artery. Remember, that's more of like your medium vessel vasculitis. Renal arteries could be involved, but a lot of the times with polyarteritis nodosa, it's like the splenic, it's like other arteries as well. This is usually only, I never say only, but it's like 85% of the time it's the renal artery, especially when it's causing like unilateral renal artery stenosis. So with this, like, again, what's happening? It's not inflammation. It's basically like this hyperplasia of the media. So the medial layer of the blood vessel wall. And then you're getting like these beaded stenoses. And this I know for sure Dr. Satar talked about. But what he's saying is you're getting fibrosis or like stenosis, and then you're getting an aneurysm, and then you're getting stenosis, and then you're getting an aneurysm. And he's like, that's kind of like what you're seeing here, rather than like true inflammation from, the polyarteritis nodosa. This is just a feature of the wall. It's just kind of strange. It's segmental hyperplasia. So it's like this is hyperplasia, it's really thick, and then it aneurysms because it's not thick. And then this is really thick, and then there's an aneurysm because it's not thick. And then here it's thick again, and then it's not thick. So that's like the alternation there. Okay, and then he talks about benign versus malignant hypertension. This is going to be benign hypertension is just basically like, okay, maybe you have a moderate increase in blood pressure. This is clinically silent, so that's kind of like a tricky concept. Clinically silent means like there's nothing bringing the patient in right now. But with this benign hypertension, even though it says benign, over time, the vessels and the organs are going to get damaged because still you have high blood pressure. Like you still have high blood. So the organs are still, everything's going to still be affected. Just like when you hear about the bad things that high blood pressure does, that's all going to happen. It's just going to happen more over time. And there's nothing bringing in the patient right now. Versus malignant hypertension, this is like severe increase. So like they say, again, this is again from 2019, over 200 over 120. That seems super high to me. This is like a straight medical emergency. Like this is like things can happen to that patient right now from having such high blood pressure. And what they're saying is there's just straight up fibrinoid necrosis occurring right then and there. So very acutely, you can have end organ damage. You can have papilledema in the eyes. You can have kidney failure. You can have headache. That's those vessels in the head kind of like bursting open. So that's kind of the difference there. Sometimes they will just ask you like straight definitions. This would be like an example when they would ask you like a straight definition. And then the only other thing that's not in here, just because Sitar didn't mention it, but I've mentioned it already, hypertensive urgency versus emergency. Learn those like, what the millimeters of mercury are for each of them. What drugs do you give for each of them? They're all in the sketchies, so you don't have to like look it up. Just keep in mind when they talk about like, oh, give this for hypertensive urgency. Oh, give this for hypertensive emergency. Kind of the same idea as like benign and malignant. Benign it might be like it's not even like an urgency, but benign is like it's over time it's going to be an issue. Malignant might be broken down. Like sketchy might break down malignant into like, oh, hypertensive urgency is when it gets to like, I don't know, 180 over 100, and then emergency is when it gets to like 200 over 120. Okay. And then arteriosclerosis, this is probably the most high yield of this entire chapter in terms of just seeing like the sheer amount of questions. So kind of, it's not hard, it's just we have to just go through, make sure we cover everything in here. So arterio means artery, sclerosis, hardening. This is literally hardening of the arteries, thickening of the blood vessel walls. And then I really like actually how Dr. Sitar broke up arteriosclerosis. I think it's a good way to think about it. I think everything he does is great though. So the first one is your atherosclerosis. This is your classic, like plaques, things that cause heart attacks, things like that. That is when the intima gets hardened. And I'll show you like a pathophys picture on that. And again, just like thinking about atherosclerosis of like, if you know someone that has high cholesterol or whatever, that's usually going to be the medium and large vessels. Arteriolosclerosis, the little olo, is now it's like smaller vessels. So atherosclerosis, medium and large. Arteriolosclerosis is going to be small, but it's the same thing. It's still going to be intimal hardening. And then Mockenberg medial calcific sclerosis. It tells you everything. It's so low yield, but I'm going to talk about it because Sitar did. But it tells you everything in the name that you need to know about it. It's of the media. It's of the aorta, and then you see like these calcifications. Okay, so number one is atherosclerosis. So that's the first pattern he talks about. So we already talked about how it's an intimal plaque, but this intimal plaque is going to obstruct blood flow. And remember, it affects medium or large size arteries. If it affects the coronary, this is like a cause of like, STEMI and STEMI. If it's a total obstruction of blood flow, that's going to be transmural ischemia, STEMI. Subendocardial ischemia, that's going to be your NSTEMI. I don't know if you guys got there yet, but that's literally what it's talking about, is this plaque that is obstructing blood flow, and it can be in any of these medium and large size arteries. A plaque, they might not always say plaque, because they know that that's kind of like a little buzzword. So what I've seen sometimes is a necrotic lipid core, so like of cholesterol, and a fibromuscular cap. That's a plaque. That's what it is. And then these plaques undergo what's known as dystrophic calcification. This is just one of those other types of calcifications that can occur. I believe, I think Dr. Siddhar talks about it, I believe in chapter 1 as well. But dystrophic calcification is just like when calcium should be there calcium binds to like things that are like dead. So calcium is now binding to like this dead lipid core in the middle, and it's basically you're just getting calcification on top of it. It's just not good. Not good to have plaques. You must know the modifiable and non-modifiable risk factors of atherosclerosis. I cannot tell you how many. I think on Comlex, when they got bored, they just threw on one of those questions. It was actually kind of insane. And it was straight up like, what is the most common modifiable risk factor? What is the most, like, they asked so many questions about risk factors. And I think it's just because so many people have this that you're definitely going to see this when you're a doctor. But let's talk about these. So the modifiable risk factors are risk factors that the patient, if they wanted to, and this is, again, whoever came up with this was their idea, could modify. So hypertension, let's say they have hypertension because of one of those other causes, like obesity, what's the other one? Age, but you can't really modify your age. Obesity is a big one. Like your salt intake, things like that, like things that you can modify with hypertension. Hypercholesterolemia, is specifically when, and this is kind of confusing, cholesterol doesn't relate to like how bad your atherosclerosis is. It's specifically about LDL, which is confusing because it's like cholesterol's in the name, but specifically they're talking about LDL cholesterol. So LDL is going to increase risk, HDL decreases risk, estrogen actually increases HDL. So that's actually why you don't hear as many women having heart attacks as men, because women have estrogen, but of course that leads to postmenopausal women are at increased risk. So things to, again, to keep an eye out for when you're like seeing patients. But estrogen is really good at increasing HDL. If you look at any woman that gets their HDL checked, they're going to be fantastic. And again, it's because of that estrogen. Estrogen is like a two-edged sword. It's so good for you in some instances, and it's just horrific for you in other instances. Can't win. Smoking, another modifiable risk factor, and then diabetes, which I guess they're saying that you can modify having diabetes. So probably type 2 diabetes. And then non-modifiable, this is stuff you really can't change no matter how hard you try. So age, okay, you have an increased risk with increased age. Gender, again, we just talked about this. Actually, Dr. Sitar, he said gender, it should be sex. He needs to get with the times. So when you're a man and a postmenopausal woman, you don't have estrogen, you have an increased risk, just right off the bat. I actually think I remember listening to the Dr. Golyan's cardio, like Spotify podcast. I think he said for like I forget what he said, but he's like, with every increase in HDL, you can take one of these risk factors off. Or so, it's like crazy how like HDL plays such an important role at decreasing risk. I'll look that up for you. I'll make like a little note to look that up because I'm curious now too. But he talks about, and then he's like, but I'll never ingest estrogen. I don't know. He like goes into it, but it's like, that's how important HDL is in terms of like keeping like atherosclerosis down. And then genetics, like while they say like family, you can't, like if your dad has atherosclerosis, you can't say that you're going to have it for sure. But family history is predictive. So it's kind of like if your dad had it, you would probably be at higher risk. Even though like, and this is what it's multifactorial. There's a lot of things that go into atherosclerosis, but family history is like one of those instances that it would help. Okay, this is like the classic picture when they talk about atherosclerosis. There's some immuno in here. So again, they think that there's some endothelial damage. So just like kind of with some of the vasculitises, there's some endothelial cell damage. So again, this is a blood vessel, right? We have the endothelial, here's the intima in orange, yellow, and then here's the media, and then you don't see the adventitia. So in here, there's some sort of endothelial damage. And what this does is it's now allowing lipids from the bloodstream to leak into the intima layer. So this orangey layer. Step 2, once the lipids get in here, they become oxidized. And then the macrophages that are present here ingest the oxidized lipids. And when you have a macrophage that ingests oxidized lipids, that's called a foam cell. So again, we have giant cells, which are just giant macrophages, and we have foam cells, which are just macrophages with oxidized lipids in them. And they look really characteristic. I don't think I put a, yeah, I don't think I put a picture in here. But if you look up a picture like right now of just like a foam cell, it just looks like a circular cell with like circles in it. It's just like you can literally think of it as like a fatty macrophage because it is. It's a macrophage that just has lipids in it. And again, I don't think they're going to show you a foam cell and be like, what is this? But it's just that's what a foam cell is. It's a macrophage. And then when you have like this increase in the amount of foam cells in the area, that's what's known as the development of like a fatty streak. So now we have like a streak of fat, which is basically just like we're increasing this now because we have these giant macrophages in this layer. So now it's increasing the amount of fat technically within the intima, and that's going to cause your fatty streak. Then you're going to kind of have like inflammation start to occur because now we have cells there that shouldn't be there. Other cells are going to come into the area, try and fix the area. That's like your areas of fibrosis. Smooth muscle is going to kind of start to become hyperplasia. So basically that's all kind of causing this necrotic core. So again, remember the plaque has this necrotic core because the foam cells are dying off after they eat the oxidized LDL. They're going to eventually die. Then you're going to have cells come to the area and try to start having like hyperplasia, fix the area. That's basically your necrotic core. And then here's your fibromuscular cap at the top here. Well, this is after it ruptured, but imagine it under the skin. That would be, well, under the skin, under the endothelial cells. That would be your fibromuscular cap. Again, it's just because of that inflammation. It's that deposition of extracellular matrix. It's basically fibrosis. And then it ruptures. Boom, that can be like if this is in the coronary artery, that can cause your end-STEMI. So a little bit more on the fatties. Here's like another picture kind of seeing like just the whole what we just talked about. So we have endothelial damage, lipids can float inward, like they can kind of now enter the intimal layer. So again, we're in the intima. The macrophages in the area can basically gobble up that fat, turn into a foam cell. Now we have, tons of inflammation happening. We have all sorts of things happening. We have fibrosis, blah, blah, blah. And then we have, here is our plaque. But this whole thing is your fatty streak. What's really interesting about this is this can actually occur super early in life. So what they say is like these fatty streaks are lipid-laden macrophages, aka foam cells, because they're just macrophages with lipids in them. You can start getting these fatty streaks when you're like a teenager. And then eventually they'll progress to a plaque. That's when the cells start to die, and that's when you get like the lipid core, and that's your atherosclerosis. That's what happens later in life. This is again another thing you should know. And I think the reason why it's like a must memorize type of thing is because these complications that can arise from having like this plaque, atherosclerosis accounts for over 50% of diseases, like all the disease states that we see in Western countries. So again, this is a lot of stuff. And they say this very broadly. Like technically they're like, oh, an MI. Yeah, that's technically an atherosclerosis complication. A stroke. Yeah, atherosclerosis So they're kind of very broadly saying that, but it's still enough where they're going to ask a lot of questions on it easily. This is like a fun fact that you should know. It was on my exam 3 years ago. If you have just stenosis, so again, if you have a plaque, the vessel is going to get stenotic, and it's like, when do you start seeing symptoms from that stenosis? And it's when you have 70% occlusion. So that's about 70%. That's when you start to see those symptoms. That's why they usually say go to the hospital when you have chest pain, or when you have, that would be like a symptom of 70% narrowing. Don't wait until it gets to 100%, because that's when you die from like a sudden heart attack. You can also have a plaque, like the plaque can rupture and then you can get a thrombus. Plaque can rupture, you can get an embolus, so you can shoot it off and send it somewhere else, or you can have an aneurysm. Okay, these are just kind of straight from Sitar, so I'm going to read through them kind of quickly, just because like this should be like almost like a second pass. But if you have stenosis of your medium-sized arteries supply organs. So you can imagine this is going to cause ischemia to whatever organ is stenosed. So if I have stenosis of my popliteal artery, that's going to eventually over time lead to peripheral vascular disease. of my coronary artery, that's going to be like my angina, my chest pain. Mesenteric artery, that's going to be like, could cause like an ischemic bowel, could potentially cause like infarcts of the watershed regions, things like that. If the plaque ruptures and then forms a thrombus, that's usually going to be right at the neck of the plaque. So if we go like right here, and this is exactly what it showed you, it's going to rupture like right, I mean, actually this is before it ruptures, but it's fine. It's right at the neck of the plaque. So it's like going to kind of stick to the, like kind of exactly what's happening here. It kind of like sticks close to the side. Platelets can form there, and that's what it's showing here. Like platelets can kind of come here and then stick to it. And that's going to be your thrombus. And then, of course, whatever artery you're in, if it's a coronary artery, you can have a heart attack. If you're in the like the MCA, you can have a stroke, an MCA stroke. Here is a plaque rupture with embolus. So this is something they can just totally show you this slide and be like, what, like basically like, what is this? What is this a slide of? This is an atherosclerotic emboli. So this would be like, let's say you had this in the heart, but it didn't form a thrombus. It actually broke off and it embolized and it went up to the brain. And then they find it in like the brain. They literally find this from like a cross section of the brain. You know that this is an embolus from something like an atherosclerotic plaque because you see cholesterol crystals in it. So these are cholesterol clefts. So this is like your plaque, and then you see like these very like white looking crystals. These are your cholesterol crystals. And if they say that this is from an embolus, you're like, okay, that's an atherosclerotic embolus because it's atherosclerotic because there's cholesterol in it. Another thing that can happen is aneurysm. We're going to go into aneurysms like that's one of the last things we'll talk about. That's just weakening of the vessel wall. So remember we talked about like with fibromyalgia, whatever the heck, we have fibrosis and then aneurysm, fibrosis and then aneurysm. And you get those aneurysms because those are areas of like weakness. So it doesn't take much pressure to kind of like bulge them out a little bit. So we'll talk about aneurysms in a little bit, but that's like a requirement to have an aneurysm is weakness of the vessel. Okay, arteriolosclerosis, here is your most important concept of this entire chapter. You will 1010% get questions on every test you take about hyaline and hyperplastic arteriolosclerosis. This is going to come up again and again and again in renal. Oh, you're technically in renal. So that's good because this is going to come up again in renal. But arteriolo, remember, this is the small vessels are now getting hardened. And there's two types of arteriolosclerosis, hyaline and hyperplastic. Hyaline arteriolosclerosis is basically when proteins are going to leak into the blood vessel wall, and then you get thickening that way. So you can see here, we have thickening in the wall. It's a very thick area. Hyperplastic is when you have thickening of the blood vessel wall because the smooth muscle that's present in the media undergoes hyperplasia. So when you see this, and they can just straight up show you a biopsy and be like, what is this? Is this hyaline? Is this hyperplastic? What type of pathology state is causing each of these? So like hyaline arteriolosclerosis, they'll talk about like there's pink hyaline deposits versus hyperplastic. They'll talk about how there's onion skinning. It looks like an onion. You can peel back the layers of it. But I'll show you actual biopsies. So hyaline arteriolosclerosis, what causes like this? You should know that for sure. Benign hypertension. So remember we talked about benign hypertension is like hypertension over time. It doesn't cause an issue like now, but it causes like issues over time because it's hypertension over time. And what happens is, again, if I go back to this one, proteins, since there's that blood pressure, that high blood pressure, proteins from the blood can actually like leak into the wall and then deposit there. And over time, that's what's causing this pink hyaline like formation thing, this pink hyaline sclerosis, basically. This can also happen in the kidney. So in diabetes, if you have diabetes, you can get hyaline arteriolosclerosis of the glomerulus. So that's your diabetic nephropathy. So in diabetes, non-enzymatic glycosylation, so basically like no enzyme is putting the sugars on the kidney. It's just they're leaking in over time, basically. They're leaking into the kidney over time. And since the blood pressure is so high, when the blood gets to the kidney, they just kind of like leak in and they leak into the blood vessel wall. And that's kind of what's allowing the proteins to leak through. And this is a picture of a glomerulus. You can kind of see, I should have put like a normal picture here, but they're talking specifically about like these areas of the glomerulus. See how they're very pink? Like it looks like there's like this pink hyaline this is when the sugars are like leaking into the walls of the glomerulus, basically. So that's your diabetic nephropathy. All diabetic nephropathy is hyaline arteriolosclerosis. And then your end result with hyaline arteriolosclerosis, the issue of having like these proteins in the walls of the blood vessel is now where, and this picture shows it the best, normally the diameter of the blood vessel is this big. When you're pushing on it, because we have so many proteins now in the vessel wall, the caliber or the diameter gets a lot smaller. So at the end of the day, ischemia. It all comes back to ischemia. So those organs that are being supplied by these arteries are going to now have ischemia because they're not getting as much blood as they're used to. And classically what you see, so I will point out that hyperplastic arteriolosclerosis also affects the kidney, but with hyaline, typically like what you'll notice when they talk about it, they'll talk about like glomerular scarring. So scarring should make you think of like, okay, this is happening over time. Like a scar develops over time, right? Like a scar is going to develop after you cut yourself and then it kind of develops over time. That's kind of how you can think about this, is like over time, the glomerulus is going to get worse and worse and worse because like, again, benign hypertension over time. And it's going to lead to chronic kidney failure. So not acute kidney failure, chronic. It's going to happen like kind of over time. You're going to get that. And that's, again, why diabetics get diabetic nephropathy. It doesn't happen as soon as they're diagnosed with diabetes. It kind of happens after like living with diabetes for a while. Hyperplastic, this is your malignant hypertension. So remember, this is kind of why I went into benign versus malignant for like a minute, because benign is, again, slowly over time, proteins squeeze through. It doesn't cause an issue now, it causes an issue later. Malignant is, it causes issues now. Like this is bad now. And it's to the point where like the blood pressure is so high that it's literally causing fibrosis of the vessel wall. And in some instances, it causes it to bleed. Even though the end result is the same, reduced vessel caliber and organ ischemia. So you can even see here, like, yes, this vessel, like, diameter gets smaller. The reason is different. So this is like, now this looks very different from this. So if you saw a slide and they asked you, is this hyaline or hyperplastic? This is pink hyaline. Like this looks like hyaline. Like it looks like that pink deposited material. Whereas this looks like, layers. Like I can peel this back like an onion. So they call that onion skinning. But this one is your acute kidney failure. So rather than chronic kidney failure, this is like patient is like having kidney failure now. And they say that the kidney has a flea bit in appearance. And again, this is because of so many pinpoint hemorrhages everywhere, because all those vessels in the kidney are just like getting obliterated from the high blood pressure. Here's your summary, your compare and contrast. Again, try to see as many pictures as possible because this is one of those things they can ask you to identify. A lot of the times, though, which is nice, they'll stick to like, the very thick pink hyaline for the hyaline versus the more circular kind of like looking ones for the hyperplastic. But in summary, pink hyaline membrane is for your hyaline arteriolosclerosis. Proteins leak in slowly over time. It leads to thickening and like that decreased caliber. And that's going to be like your end organ ischemia. Benign hypertension, diabetic nephropathy, those are like your main causes of these. And it presents with chronic kidney failure and glomerular scarring. Versus hyperplastic, your onion skinning. So it's not proteins leaking in, it's smooth muscles now undergoing hyperplasia caused by malignant hypertension and then acute kidney failure and fibrinoid necrosis. It's literally just like causing the actual wall to die. And that's what you're seeing with the onion skinning. Okay, third one, this is super low yield, but something that I did want to mention about this one is whenever you see like calcific, like dystrophic you can see dystrophic calcifications in many different pathology states. This is basically like a dystrophic calcification of the aorta. It's not ever like a bad thing, so to speak. And what I mean by that is just it's an incidental finding sometimes. Like it can just be something you see on x-ray. If you see calcifications on x-ray, it doesn't always mean like, oh, it's cancer. This one though is really weird. It doesn't actually change the caliber of the vessel because it's just depositing within the media. So you can see here, like the media has these calcifications in them, all right here, but it doesn't change the diameter of the lumen. So what's interesting about this is it's non-obstructive. You actually don't have to treat this at all. It's just an incidental finding. All right, aortic dissection and aneurysm. Aortic dissection, this is when the intima tears, but then the issue, like blood is going to pool then in the media. So I'll show you a picture of that. That's kind of hard to like visualize, I feel like. All aortic dissections require two things. These are need to knows. Stress. So you need high pressure basically. And that's why the most common area is the proximal 10 centimeters of the aorta. I mean, imagine you have to shoot all the blood for the rest of the body out of the top part of the aorta. So that's the most common area of the dissection because that's a high stress area. And then some sort of pre-existing weakness and this of the media. And you can technically see this with older patients that have hypertension. So if you think about like a benign hypertension, someone that has benign hypertension, they can have hyaline arteriolosclerosis of the vasa vasorum in the aorta. And if you have basically decreased blood flow now to the aorta, you're gonna basically have atrophy of that media. Then the media is gonna get really weak, and then that's a perfect area to go boom and dissect through it. But why you get atrophy is because we have decreased blood flow, so we're gonna have decreased oxygen. If you have aortic dissection of like a younger patient, that's some sort of inherited defect. Because again, this is usually a hyaline arteriolosclerosis. That's benign hypertension, which is like over time. If you have a younger patient with it, it's usually because of like there's some sort of inherited defect with medial weakness of the medial connective tissue. So what they call this is cystic medial necrosis. So again, you have like this inherent defect of the media. So the two common ones are Marfan and Ehlers-Danlos. These will both come up when you get to MSK in pathoma, and you'll go into it in a lot more detail. But in Marfan disease, fibrillin is defected, and in Ehlers-Danlos, collagen is defective. Both of these would predispose you to aortic dissection. So here's kind of just a visual to help see it. So remember, like one of the things that can happen is the vasa vasorum can undergo, oh my God, what's the word? Hyaline arteriolosclerosis. So they can kind of get like weaker over time. So then the media is going to get weaker because these are supplying, the adventitia. It goes kind of like the coronary arteries. It starts where it's closest to, and then it supplies going from closest to furthest. So the media can actually get like just weaker if these are kind of taken out. So with that, when the media gets weaker and we have some sort of like intimal tear, again, usually due to high stress, both of these kind of play into a role, and now blood can kind of pool within the media layer, and that's your aortic dissection. This is all stuff to look for in a patient. You can literally save them if you can diagnose this quickly. Sharp tearing chest pain, like a tearing, like again, think about like you're tearing through these layers. It's going to feel like it's ripping through them, and it radiates to the back. Because again, it's going to kind of go now from the aorta. It's going to go through those layers. It's going to feel like it's going to the back. And this is when you want to order a chest x-ray. A lot of the times, like people order EKGs for when they have like chest pain, but then if you miss that they might have a dissection, you will miss this mediastinal widening. And this is like a very common indication that the patient has an aortic dissection. Most common cause of death is actually cardiac tamponade. So look for Beck's triad. I put it on like a future slide. So again, hopefully it makes sense why you would have I have a picture to kind of visualize why you would get like a pericardial effusion with a dissection, but it can also cause rupture of the aorta with hemorrhage. Like the aorta itself can just rupture rather than like going into like the pericardium and just kind of pooling there. It can literally just burst open the aorta, and then you can just bleed into your like thoracic cavity and die that way. Sorry for that image, but it can also cause an obstruction of like the branching of the branching arteries with aortic organ ischemia. So like the aorta is a very big organ, and it goes along all the other, like it can like literally lean up on like the esophagus. It can lean up on like the renal arteries. So you can actually get like end organ ischemia of other organs as well. So there's different things that can cause issues in aortic dissection, but you want to catch it like mediastinal wide. You really want to catch it as soon as possible. Another thing to point out is with dissection, they can show you a CT scan, and then you can look for, there's a true lumen and then a false lumen. So a true lumen is like, what's the actual lumen of the aorta? And what's the lumen of after the blood went through the intima and entered the media? Blood's gonna pool there until it either bursts or, leaks into the pericardial cavity. So I like this picture. I like this picture from seeing that. So here's the true actual lumen, like actually of the aorta. But you can also, when you get the tear and then it leaks into the media, you can also get like a second lumen. So they call that a false lumen. So the true lumen, normal lumen, that's by your intima lines that. The false lumen is literally within the media. Because again, it's kind of like, here's your true lumen here, and then this would be like your false lumen if this now started to pool, if blood started to pool here. So that can actually look like this on a CT scan. So we know we're at the aorta. We see like, okay, this is like the branching. Like we see all that. We see like this is the aorta here. I actually had a true false lumen question on STEP. They showed me literally a CT scan. It was like, which one is the true and false lumen? So with this, how to diagnose which one's the true lumen, which one's the false lumen? The false lumen is always bigger. Oops. Oh, I thought I labeled it. Oh, my bad. This would be the false lumen. So the false lumen is always bigger because, again, like your aorta in general is not supposed to be that compliant. So we wouldn't expect the normal true lumen to move with blood. But now since we've dissected it, we went into like the next layer. That's like not at, that's not going to be at, it's only covered by media and adventitia. The intima, the true lumen is covered by intima, media, adventitia. So it's kind of like it can actually pull more in there. It's a little bit more compliant than the true lumen. So it's a little bit bigger on x-ray. So if they showed you this, the false lumen would be the bigger one. And it usually does tend to look a little darker, but I don't always see that. So just which one's bigger, which one's smaller. And then here's kind of another picture kind of seeing how tamponade or aortic dissection can lead to tamponade. So remember, it's always like the proximal 10 centimeters of the aorta, which is like right after it leaves the aorta. So if it dissects right here and then it starts to pull, so this would eventually pull, and then maybe it'll like break open. And instead of breaking open into like the rest of the body, it breaks open into the pericardial cavity. And then you have tamponade with Beck's triad. So here's your Beck's triad. You have low blood pressure, you have muffled heart sounds, and then you have a jugular venous distension. And again, that's when you have your pericardial effusion. You can die from that. Okay, and then thoracic aortic aneurysm. This is like when the thoracic aorta becomes dilated. This is caused by weakness of the aortic wall. All aneurysms are caused by weakness of the aortic wall. But what's really high yield with thoracic aortic aneurysms, I was super excited to talk about this because this is your micro plug. Tertiary syphilis can cause thoracic aortic aneurysms. And I actually remember I brought in a question, like I tried to find it. I couldn't remember which tutoring session it was that we did. But I brought in a question. I had to tell you guys like, oh, this is syphilis because they talked about signs and symptoms of a thoracic aortic aneurysm. I had to tell you this is syphilis or something. Or it said like the patient had syphilis. I had to tell you that it was an aneurysm. I forget. But they're always related. It's like, it is classic. Like it's always going to be like tertiary syphilis is going to cause a thoracic aortic aneurysm, just like it's going to cause tabes dorsalis. Syphilis is like a vasculitis. Like I just kind of think of syphilis as like a vasculitis, especially tertiary syphilis. It's a vasculitis. So what happens with syphilis, it's kind of the same idea. It kind of causes inflammation of the vasa vasorum of the thoracic aorta. And then eventually over time, it's kind of that same thing we've been seeing. Over time, you're going to get like the layers are going to start to die because they're not getting blood flow and you start getting atrophy of this wall. So they call this tree barking of the thoracic aorta because this literally looks like a tree trunk. Like if I were to zoom in on that, I'd be like, yeah, that's like a grandfather tree. No, this is the aorta that has become scarred and is gross. And it's because it's losing its blood over time. That's what tertiary syphilis does. I remember that's what it was. I wanted to bring in the question for aortic regurg. It was like a murmur question about aortic regurg. And I had to tell you that this was syphilis causing aortic regurg. And it was like, why is syphilis causing aortic regurg? Now you know. So when you have like this thoracic aortic aneurysm, since the thoracic aorta is like increasing in size, it actually pulls like the aortic valve, it can actually like pull it. It just stretches it a little bit. So that's causing your valve insufficient. So they say it's like, oh, it's dilating the aortic valve root. So literally like where the valve is, it just stretches it. And then, I mean, imagine it can't close as nicely when it pumps. So there's your regurg. It's insufficient. But you can also get compression of mediastinal structures, kind of like with the aortic dissection. You can get compression of mediastinal structures as well. But in this instance, you can also get like an embolus or a thrombus that can develop from this aneurysm, and then it can deposit. Because now it's like, think of it, it's like we're like widening, so blood can technically pool here. Technically, I really don't see that. I really see about thoracic aortic aneurysms, I see about the syphilis questions, but the blood technically can pool here because there's more space for it now, and then it can form like a thrombus or it can embolize and go somewhere else. Okay, AAA. So before we end with vascular tumors, so AAA, your abdominal aortic aneurysm. So this was up in the thoracic aorta. So again, we're up a little bit higher. Now we're in the abdominal aorta. So anatomy is very important here. So I think I meant to take this out of your guys' PowerPoint, but I left it in. But if you didn't look at what level it's at, this is the same idea. You have this balloon-like dilation. Again, that's what all aneurysms technically are. The most common, and this is the place they will give it to you if you were to get like an abdominal aortic aneurysm, it's going to be below the renal arteries, but above the aortic bifurcation. So what level would that be? But you guys probably already have it. But if you didn't look.
The bifurcation is at L4.
Yes, good.
So it would, and then the
Bifurcation.
renal one is L1, L2, so somewhere between.
Perfect. Perfectly put, yes. So between L1, L2, and L4. That's just where it's going to be. It's just going to be between these two levels. Anything above this, that's going to be your thoracic aortic aneurysm. Okay. And even when you see pictures of it, did I put any other picture? I think I did put, yeah, on the next slide, I put another picture in there. It's between the renal arteries and the bifurcation. So that's typically where this one usually is. This is always caused by atherosclerosis. Again, you would have to imagine, though, it would have to be like pretty serious atherosclerosis to take out the abdominal aorta, which is massive. But classically, it's going to be a male, a smoker, and older, and has hypertension. So not only are we damaged, because again, remember with aneurysms, you need damage to that wall if it's not going to be like a Marfan syndrome or something like that, where it's like the wall is already kind of structurally deficient. You need like things that are going to increase the likelihood to damage the wall. So smoking, age, being a male, having hypertension. These are all risk factors of atherosclerosis. This is your classic AAA patient. And then this is saying like why it's kind of like the same idea as like the thoracic aortic aneurysm, which the issue with this one is your, oh, we didn't really talk about it. Oh yeah, we did. The vasa vasorum kind of has vasculitis of the vasa vasorum. So then the media is going to eventually become like, it's kind of the same idea with the dissection. It's kind of like, I know I drew it. Yeah. If these guys get taken out, it's like the layers furthest from it are going to get weaker and weaker and weaker. It's kind of, again, like the coronary artery. If you take it out, the subendocardium, the furthest from the coronary arteries, are going to be the most at risk of losing oxygen. Same thing here. If we take out the vasa vasorum, the ones furthest from the vasa vasorum are going to be the ones that are going to be the most at risk at losing oxygen. But it can especially manifest as the media, because the media is the thickest layer. That's going to be the one that's going to be troubled the most by it, because that's the one that needs the most oxygen. That's your muscular layer. That needs tons of oxygen. So that's going to be really, really struggling. So it's kind of just like thoracic aortic aneurysm. This is when the syphilis basically takes out the vasa vasorum. This is kind of like atherosclerosis is kind of just making the wall itself just thicker. And now we're increasing that diffusion barrier to the media from the vasa vasorum, and that's why we're getting atrophy and weakness. Makes sense? So it's always, honestly, for like pathology states, especially in cardio, it's usually due to ischemia. Even the vasculitis it's like due to ischemia. It's just like various versions of ischemia. And then, so having a AAA is like fine. It's not great, but it's fine. But when it ruptures, that's the issue. And usually it's going to rupture when the aneurysm gets greater than 5 centimeters. I don't know how important that is, but 5 centimeters to me doesn't seem like it's that much. But that's when it ruptures. And the triad you're going to want to look for, I mean, I think just having this in, like just having a pulsatile abdominal mass is enough for me to think that, it's a AAA. But if you have a pulsatile abdominal mass, obviously that's your aorta. Hypotension and then flank pain, because again, I forget what the retroperitoneal structures are, but I think the abdominal aorta is retroperitoneal. I'm pretty sure. So that's why you'll get like back pain. It's a different reason than like an aortic dissection why you would get, so not flank pain, but with aortic dissection, remember it's they feel it radiating to the back, and it's just because it's like the blood is ripping from the intima to the media, which is like it's going through the layers like backwards. So it kind of feels like it's going backwards. This is like you're getting back pain, flank pain, whatever, because it's a retroperitoneal structure. And then, as we saw with the other two, you can also get compression of local structures. What's located around here is the ureter. So that's just like an anatomy thing. You can also get an embolus and a thrombus, just like the other ones. Okay. Vascular tumors. Okay. So this is kind of where I was talking about blanching versus non-blanching. This is kind of where it becomes a little important. So hemangioma, this is a benign tumor of blood vessels. So literally blood vessels just start growing. This is commonly present at birth. You don't need to remove it. This is where they're going to get you. They will show you a hemangioma. And the reason I do want to go into this now is because these are also things that are going to come up in pathology states moving forward. Especially a lot of the neuro path is like, oh, presents with a hemangioma, or oh, presents with, what's next? An angiosarc, like it'll just come up, like they'll just come up in pathology states. So hemangioma, blood vessel, a tumor. But they'll show you a picture of it and then be like, what's your next step? You don't have to do anything. Nothing. It will go away entirely on its own. They just completely regress after birth. You can see them on the skin. You can also see hemangiomas on the liver, but they're totally fine. They'll go away. This one, though, if you press on this, it will blanch. So they'll show you this and then be like, if you press on this, it will blanch. That means like it'll turn white when you press on it. Because again, these are blood vessels. If you push on them, they can like go away. They can go up the blood. Like the blood can go up the blood vessel for like a hot sec, and then it can come back. Purpura has nowhere to go. It's in the skin. If you push on it, it's just going to stay. It's not going to blanch. Okay? And I really only emphasize that because this is sometimes the only way you can differentiate between like certain skin things is if you press on it, does it blanch or not blanch? This is an angiosarcoma. I just put a slide here. They'll never give you a slide. Like this, they'll show it to you and be like, what is this? They will never do that. I just kind of wanted you guys to see it. This is, again, angiosarcoma. If you guys remember from cancer stuff, sarcomas are always malignant. So this is like a malignant cancer of the blood vessels, angio. And then this is going to be the endothelial cells of the blood vessel, basically. So you can see this in the skin, the breast, the liver, whatever. But the liver angiosarcoma is associated with exposure to PVC. Also arsenic, and then thorotrast, which I think is like a radiation. I think it's like a radiation or like a radio labeled compound, something like that. But PVC is like the big one to know. I know that there's like, I think there's in the cancer chapter, there's like, oh, being exposed to this leads to which cancer later in life. That's like something you should know for boards. So this is just like a tie-in to that. But it would basically be like if this is the blood vessel right here in the middle, the endothelial cells lining the blood vessels would become cancerous. And that's kind of what all of these cells are. These are cancerous cells. And then Kaposi's sarcoma. Kaposi's is another micro plug for this chapter. So this is a human herpes virus 8. Do whatever you need to do to remember it's 8, because they will always put like HHV6, HHV5, like they'll put all the human herpes viruses when you're trying to answer these questions. So HHV8 causes Kaposi's sarcoma. It's malignant, so it 100% is malignant. This is of the endothelial cells that line the blood vessels, so kind of similar to the angiosarcoma so far. But now this is associated with HHV8 virus. It's going to present as purple patches, plaques, skin nodules. This is kind of just like, I think this is, oh no, this is just a picture I kind of found. It kind of looks like purpura. And it also doesn't blanch when you press on it, just like purpura. And hopefully that makes sense why these won't blanch. These are literally endothelial cells that are malignant. So it's not even really blood. They just kind of get malignant and get bigger and look purple. But these can also affect the GI tract and the lungs. But what's more important is to understand, like, Kaposi sarcoma is HHV8. Who gets these? Who gets HHV8? Who gets Kaposi sarcoma? And it's going to be not only your immunocompromised patients, so you will have immunocompromised, so that's your HIV/AIDS patients, also your Eastern European males. Super weird. Russians, older Russian people tend to get, males though, older Russian males tend to get Kaposi sarcoma. It's like a geographical thing. I tried to look into why when I was learning about this. No idea. But if you do get the Kaposi sarcoma for the Russian, like the one that's more like a location one. So like again, these Russian males, not the immunocompromised one, it can't go to the GI tract and it can't basically progress. It's gonna stay localized to the skin. So because it stays localized to the skin, you can actually treat it by you can just surgically remove the lesions and then they're good to go. But more commonly, you'll see Kaposi sarcoma pop up with your HIV/AIDS patients and then your transplant patients. So again, your immunocompromised patients. With your HIV/AIDS patients, the tumor is going to spread, so it can go to the GI tract, and go to the lungs. It can go pretty much anywhere. It's not just going to be on the skin. But you want to treat it. It's really weird. You're not going to treat the HHV8. You're actually going to treat the HIV. So you're going to give antiretroviral agents to treat this Kaposi sarcoma for an HIV patient. And then with transplant patients, kind of the same thing. They're immunocompromised, so it can spread really easily. So how you're going to treat it, you're not treating HHV8. You're treating it by decreasing whatever type of immunosuppressant drug they're on, whatever like chemo they're on that's causing the immunosuppression following a transplant. Because your immune system can easily fight off HHV8. It's just like it can't at that time. It's like trying to either fight off HIV. It's being suppressed because of a tumor. But with the Eastern European guys, these are the ones that are you can just take off. You don't even have to treat it. You just remove the lesion. It's good to go. My God, that was longer than I thought. I'm so sorry. It's 5:07. Do you guys want to do like one question just to kind of see maybe I'll pick like a good one. I just kind of want you guys to see how to like think about these things. Hold on, I think I want one of these. Yes, okay.
We talked about like only 3 of us today.
Yeah,
Back to the normal gang.
the normal gang. Don't worry, I'll try my best to keep it like that.
That's okay. When I was like looking at this, I was split between like giant cell versus polyarteritis because of the hepatitis, but I think I would pick D just because like so common, but also I like was like hearing Christina being like, "You guys got or something." So I'm split, but I think it's that one, but I don't know. I forget which one had ulceration. Back. What do you guys think?
I agree.
With what part, Nay?
D.
Nay just goes, yes. All right, you guys are right. I'm not gonna let you guys sit here be tortured. Yes, you guys are right. I'm gonna be better at that, Jay, I promise. Another thing with giant cell, 50-year-old man. And I know I said like you don't always have to kind of use like, greater than 50-year-old female for a giant cell, but if you're between two and it's a 50-year-old man, you can be like, okay, this is probably not giant cell. If you're like just straight up between two.
Yeah, I couldn't remember if it was 50-year-old, like just in general, or
Oh, okay.
it's female. Yeah.
Yeah, giant cell is greater than 50 females almost exclusively. Polyarteritis nodosa is usually in males. It's usually in middle-aged males. And they gave you, I was surprised, Amboss gave you like 50-year-old, like middle age as it gets. I was like, wow. That was good. All right. Um, I lied. I want to do one more. Hold on. Hold on. Don't read them. Okay. Yeah, this is where I think it can get kind of confusing. These types of things where it asks you to like describe what they're seeing. Yeah, so this is like again, but if you want, you can tell me what you think it is and we can go from there.
Since the Takayasu one, right?
Yes. I'm sorry,
Why did you laugh like that?
I'm just laughing at Naomi's thing to me. Yeah, you can't take a pulse. I told you you're gonna be thinking about it. Yeah, so weak upper extremity pulses. That's Taki. They even gave you like a young woman from Japan. Like they gave you an Asian woman that's under 50 with no pulse, like with decreased pulses. That's Takayasu. Good. Okay. Does anyone remember anything about Takayasu in terms of like granulomas, non-granulomas, which layers of it, blah blah blah.
It's granulomatous.
Good. Okay.
It's not intimal.
Good. It's not intimal.
I mean, the only one that has like granulomatous in the answers.
You guys are so good. Wow, you're making me feel bad about myself. I thought these were so hard. Um, Good. So something I wanted to mention too, subendothelial immune complex deposition. Which one is this one talking about?
Enoch,
Mhm.
something.
Yeah,
Yes.
IgA.
What about this one? We had one slide on this one. Very, very brief.
Mock.
Piece.
Mm-hmm. Maki. All right. And then these were the ones that I thought you would get to. But you guys did a good job. It's not, there is a granuloma. That's enough, kind of. They didn't really give you much of the other ones to kind of go through. But what I want to show you too is, so this is in here with the other answers. This is kind of, I liked this picture from Amboss. It kind of showed that the ascending aorta also kind of gets dilated from this. And then you get stenosis in other places, which is really interesting. So that's where all these like white arrows are showing. It's kind of like the stenosis in the other areas. It's just kind of cool seeing this, but it is like it is a vasculitis thing. And then this was, yeah, the other commonly picked one. It was polyarteritis nodosa, your fibrinoid necrosis. That's like the necrosis, and then like the inflammation, and that's what's causing like the nodules that you see. And then just the other ones. Well, that was quick. Um, I mean, we can keep doing that. Oh, you guys did that one. Oh, wait. Yeah, let's do this one. Sorry, last one, I promise. I'm just so impressed. You guys are getting these.
feel like this one's harder. Can we talk about this one?
Yeah, this is the harder one. That's I forgot where I put this one. This is the one I wanted to go over.
She's got purpura, palpable purpura, but that's not really that helpful, I guess.
Yeah, because I remember you saying purpura is not really specific.
Yeah.
I just feel like the giveaway, like Lexi said, would be the radial pulses.
Yeah.
That's like kind of
That's
the
like the
only thing that would, yeah.
only thing I see, or like joint pain. I feel like a few of them have that.
I think I remember you saying that the polymyalgias are non-specific too.
Yeah, I think we would all pick E on the exam. So let us know if we're wrong.
You're right. So good. Okay. You guys did a very good job at not getting got at the polymyalgia rheumatica. I feel like that's sometimes like a jumper for GCA or temporal arteritis in this instance. But it's not. Also, her age, 24-year-old woman. Again, you're really not going to see GCA in someone under the age of 50. I haven't seen it yet. I even tried to look for a question where they're younger. So it'd be like, oh, don't use age. But I'm like, oh, it's like, you really can't find it in a patient under 50. But that's what it says. You guys did a good job at that as well. The other thing too was, what was it? Oh, it sounds just very like the polyarteritis nodosa. Like I was also thinking you might get got with the purpura or like just the nodules that you see because 40% of the time you see skin lesions with polyarteritis nodosa. But you guys also didn't fall for it. I'm so proud. Very good. But do you see also too how all the questions are gonna have like all of the vasculitises in them and they're all just gonna be there. Well, I mean, at this point, how about this?
This one, I feel like I was team like Kaposi versus polyarteritis.
What were you between?
Polyarteritis and Kaposi.
Oh, I actually genuinely have no idea what this person has.
All right, so I'll go with C2 then.
Yeah, this is a straight up like you should be able to figure it out with what they give you the features of these things.
Is it like in the not blanching with pressure part?
Hmm.
Um, yeah,
So hemangiomas, they blanch, right?
Yeah.
So wouldn't be B. Angioma, spider angioma is like, is that similar as a
Yeah, we didn't really talk. You guys will learn about those in GI. That's like a liver issue, but those also blanch.
ecchymoses are bigger, petechiae is smaller, erythema is like just like redness, right?
it's a rash. Yeah.
So yeah, see.
Very good, guys. Very good. Yep. And then I wanted to kind of show you guys the pictures too. So here's your purpura. They're 4 to 7 centimeters, I guess. This is your petechia. So these were the top two, was petechia versus purpura. People kind of confuse those a lot. Purpura are bigger. They're just bigger than petechiae. Ecchymoses, this is the picture that they provided. I think that's a kind of weird picture of an ecchymoses, but fine. But they are really big. As you said, here's your hemangioma. It'll blanch when you press it. Press it. Oh. This is your spider hemangioma. So a lot of people have spider hemangiomas, like a lot of people. Oh my God, sorry. And they look like little spiders. Like they have like the little things. That's usually a sign of like liver issues. But those also blanch. But yeah, just wanted to show you guys those. I mean, it's up to you guys. You want to do the rest on your own? They're just like in a weird order now. You have to kind of go through them. I mean, I'm also down to do more. I don't mind.
Don't you have another session after us? You should just take a break and relax.
Yeah, well, let's do one more.
One more for the road.
For the road, for the road. But you guys have to get it right then, because then we can't end on it if you guys don't get it right.
He has Weckner's with the C. It's a C, you know. I was like, when Tatham said that, I was like, wow, that's so stupid. And it works. It works so well.
I do it
It
too.
works so well. And it's just so annoying how well it works.
He does that so much. I'm like, that's so stupid, but I'm like, it's genius.
I was like, where is he going with the C? And then now I always use it and everything.
These are literally Nazis.
I think we got it though with E. I'm assuming since we're not saying anything.
Yes. Good job, guys. The C. This is Wickeners. But I also like the picture that they provided with the C Inca. Which again is just your white blood cell, just antibodies against the cytoplasm of the white blood cell. Yeah, versus P Inca. That's your granulomatosis with polyangiitis. Oh. Wow, I'm very impressed. You guys know your vasculitis is. So I'm gonna send these to you. Do the rest of them. I don't know how many there are left, but just keep in mind you'll have to scroll through them. Just because like now they're in like a weird order. Oh. Then like so just kind of scroll through, be like, oh yeah, just okay. But yay. Good job, guys. You're so welcome, Emily. Stop. I